Thank you, Mr. FC. Honorable Minister, the special guest of honor, Chief Director, honorable distinguished ladies and gentlemen, shall we be upstanding for a short prayer? Shall we pray? Our Father and our King, we are extremely grateful unto your name for a day like this. Heavenly Father, I want to thank you, Father, for bringing us here, granting us your traveling mercies from within and from afar. Once again, we've met here, O God, to take stock of what we have done as a sector and also try to explore sustainable financing strategies. We want to ask that, Lord, your Spirit, O God, guide us and grant us the spirit of wisdom to be able to navigate through all our discussions. Take absolute control over everything that will transpire over here. We want to pray that, Father, will have the mandate of the sector in the light of the challenging strategies, in the light of challenging issues regarding our financing landscape. We want to ask that, Lord, you grant us whatever it takes to be able to meet every expectation that we've set up to do. Father, we are bringing all people that have gathered in here, the echelon of the health sector that are meeting here to discuss these issues. We want to pray that you grant us the wisdom and the knowledge and the direction so that in the end, whatever we decide on will something that will go a long way to affect the life of the people of this country, which we have entrusted onto our hands. This and many more that we ask in the name of God the Father, God the Son, and God the Holy Spirit, we humbly pray. In Jesus' name, amen. Shall we humbly take our seat?
Thank you, Dr. Nkansa, for that prayer. At this point, I have the singular honor to introduce some special guests in our midst. So the ushers will help us usher them to the high table if we have some seated in our midst this morning. We have Mr. Bright Emisa Nyako, the National Chairman of Ghana Coalition of NGOs for Health. If he's here, let's acknowledge him. I'm very sure he's on his way coming. We have Mrs. Uzuamaka Gilpin. I'm sure I got it right. The DP lead Foreign, Commonwealth and Development Office here in Accra, right with us. Thank you so much for coming, madam. Let's acknowledge her. Honorable Nana Yao Ayo Efriye, Chair, Parliamentary Select Committee on Health, is honorable with us. I'm sure he's on his way coming. All right, okay, he's on his way coming. Thank you so much. We have the host himself is here. He's a member of Parliament for Doma Central. He is the minister responsible for health, Honorable Kweku Ajiman Menu. We are privileged to have a special guest of honor in our midst. He is in the person of the World Bank Country Director for Ghana, Liberia, Sierra Leone as well. No other person but Perry Laporte is with us. We have the Chief Director of the Ministry of Health also with us, Alhaj Hafiz Adam. We are privileged this morning to have the chair for the occasion, but I understand that we have others who are also joining us online. We are honored this morning to host you. We are going to be 4 MCs for this whole occasion. We have Dr. Linda Vanotu with us, who is online. We have Mr. Benjamin Nyakuche also with us. Mr. Kwame Dea Samuel Tre is also with us. And my humble self, Naftali Cheba, will be hosting you this morning. We'll cross over online, hand over to Dr. Linda Vanotu to do a quick introduction of some dignitaries who are online as we proceed. Doctor, if you can hear me, take over. That is technology for you. Okay.
Thank you very much, and it's a pleasure to welcome all participants online joining this year's conference. I work with the USAID Accelerator Program and under the Results for Development. We have 117 people online now. That 118 keeps improving or increasing, and it's a pleasure to welcome everyone. We have Elizabeth Williams, she's joining from the USAID. We have others online. Some of them have not shown where they are joining from, but we have UNICEF online, and we have many people online. Like I said, over 100 of them. So once I get the organizations that are joining online, we'll be happy to name them. But we have, for example, Dr. Henry Nagai from JSI. We have others who would show their organizations of affiliation, and I'll be happy to bring them back. So over to you. We'll come back with the others. Thank you.
Very well. Thank you so much as well, Doctor. We're expecting Dr. Francis Casolo, WHO rep, to also join us very soon. Doctor is here. Doctor, please move to the high table for us. Ushers, please help us. Let's acknowledge him, WHO rep to Ghana. Thank you so much for coming. At this point, ladies and gentlemen, I have the singular honor once again to introduce the chair for this occasion. It is no other person that a man personally I also admire so much as well. There's something unique about him, he will tell you. He is the board chair of the University of Ghana Medical Center. He retired from the World Health Organization in 2017, where he had worked for 20 years, 10 years as the Deputy Director General and 10 years as an Assistant Director General. Before joining WHO, he had worked through all levels of the Ghanaian health system to the very top. He was appointed the Director of Medical Services in 1997. Before then, he was the Director of Policy Planning, Monitoring and Evaluation at the Ministry of Health, a Deputy Regional Director, a District Director of Health Service, and a Medical Superintendent of a District Hospital, and also a distant primary health care coordinator. This man is currently the presidential coordinator for Ghana's COVID-19 response program and the chairman of the newly established National Vaccine Institute of Ghana. It is no other person than our own veteran, Dr. Anafi Asamoah Bah. Let's welcome the chair for this occasion. We can still do it better for him. Or let's keep doing it until he gets here. He really enjoys hand clap, I know. Doc, the last time you said something. I remember the last time we had a program here, he says at least he's taller than the MC. It has not changed. Welcome again, Doc. Let's welcome him to give his opening remarks as he comes to the podium.
Thank you, MC. Your Excellency, Minister for Health, Your Excellencies, our special guest of honor, dignitaries on the high table, distinguished ladies and gentlemen, colleagues and friends. Thank you for inviting me, and thank you for asking me to be the chairman for this year's summit. As you know, Ghanaians love titles, and one of our favorite titles is the title of a chairman. This title was made fashionable by a former head of state, Chairman Rawlings. Since then, everyone wants to be a chairman. That's why we have Chairman Esiedu Ketia, Chairman Wontumi Senior, Board Chairman Freddie Blay, Karachi East Constituency Chairman, You get my drift. Last year, I was privileged to be invited to be the special guest of honor. This year, you've invited me as the chairman. Thank you for the promotion. I've been wondering if I'm invited next year, what will be my title? Presiding chairman, chairman emeritus, chairman general. I must confess, of all the titles around, one that catches my fancy is the title of general overseer. I understand as general overseer, all the offering, the collection, the kofiniama, they all come to you first. Praise the Lord. Your Excellencies, allow me to salute and congratulate the Minister of Health and the officials of the ministry, all development partners, and indeed all who have helped to make this year's summit happen. As you know, this summit has a long history. It has evolved over time, but interestingly, it is kept to the original format. It usually starts with an opening ceremony where we listen to words of wisdom from a number of health leaders, followed by a discussion on the holistic assessment of the performance of the health sector as a whole, with some opportunities for knowledge sharing. Usually the second day is dedicated to shining light on a particular subject, and the third day we attempt to reach some consensus on the way forward, issue a communique and an aid memoir. And this year's format follows the same template. As chairman, I was looking forward to just being here, listening and learn, but I was a bit surprised that the invitation letter I received said, you'll be required to address the gathering. You'll be required to address the gathering. Obviously, the organizers have not learned their lesson from recent weeks. It's very risky to invite chairmen to address gatherings. But nevertheless, to be faithful to my remit, I will make a few remarks. The year under review has been an interesting year for the health sector. In addition to fighting COVID-19, you have successfully managed a number of disease outbreaks: Marburg, monkeypox, Lassa fever, yellow fever, polio. Some services are picking up, especially maternal and child health services. You are revitalizing programs like the malaria elimination program, HIV, neglected tropical diseases, and you are paying more attention to non-communicable diseases. So in general, I will give you a B, maybe a B minus. The minister is looking for an A. Unfortunately, you got a B because in my view, there have been three unfortunate developments. One is the shortage of childhood vaccines. The second is the growing wave of brain drain, especially of nurses and doctors. And the third is the astronomical increases in prices of medicines and diagnostics tests. Given my background, I am really excited that the topic you've chosen to highlight this year is financing, sustainable financing. I believe the key to sustainable financing is domestic resource mobilization. Fortunately, as a country, we have an excellent framework. We have a special levy to finance health services, but its impact is suboptimal because we're struggling to deal with four main hurdles. One, the insurance levy is not generating the quantum of resources anticipated. Two, what is generated does not get to the National Health Insurance Authority. Three, The National Health Authority is struggling to play the role of strategic purchaser. At the moment, it plays the role of strategic paymaster. And we still have not tackled the wastage and inefficiencies in our system. We all know that at least 30% of all the medicines and all the lab tests we prescribe to patients are not necessary. So I believe any serious financial strategy must address these hurdles, and I'm really glad that the document we're going to discuss attempts to do that. But more importantly, I'm happy that it builds on the last financial strategy developed in 2015. This was developed at the time I was in WHO, and my verdict on that document was that it was too academic. It did not address the specific challenges of Ghana, and I'm not surprised it has not really impacted on health financing in Ghana. What we have before us is less academic, but still requires, in my view, some work. So let me take the privilege of the chairman to just highlight a few areas that, in my view, can benefit from some more work. And I'll be very brief. This strategy is meant to finance universal health coverage roadmap. So one will expect that it will be more aligned with the ideas and the language in the roadmap. At the moment, it doesn't quite do that. The roadmap identifies some specific services, and recognizing that financing outpatient services is slightly different from financing emergency. This document doesn't really cover that. But my biggest concern with the document is that it seeks to redefine primary healthcare services as services delivered at the health center and below by physician assistants. This is very different from the definition Ghana has used from 1978. I think this is unfortunate, this is ill-informed, and this is dangerous. Without hospitals, we don't have a primary healthcare system. COVID has taught us that the days where hospitals were bad, health centers and chips were good are gone. You need a network of providers. And I will be happy that hospitals are included in the proposed network of practice. That is really my main criticism. But there are two other areas I will also think they could benefit from strengthening. One is to do with timeliness, some emphasis on timeliness of resources. Our COVID response was possible because of initial strategic support, the $100 million provided through the World Bank. It made all the difference. Wearing my other hat, on behalf of the government and people of Ghana, I would like to thank the World Bank, the country director, PL, for your leadership in getting us that support. The last area I would like to mention is that it will be useful to have some more emphasis on accounting of resources in the financial strategy. One of the accusations against us in the health sector is that we are good at asking for money, but not always good at accounting for the money used. In fact, sometimes when you ask health officials to account for money, they feel offended. Don't you trust me? The message here is trust but verify. For most part, from my little experience, most of the infractions we have is not so much due to embezzlement or misappropriation, but rather lack of documentation and the absence of qualified procurement experts, accounting and auditing personnel. So it will be useful that we address this as well. I hope I've not been too controversial and that you invite me to the summit next year as the General Overseer. I wish you a successful conference And let's all pray for Empress Lupita and God Papa the Greatest. Thank you.
No comment on this one. Thank you so much, Chair. At this point, ladies and gentlemen, I call on the Chief Director of the Ministry of Health, Alhaj Hafiz Adam, to give us the welcome address.
Mr. Chairman, it appears I'm also taller than our MC. Go. Mr. Chairman, our special guest of honor, outgoing country representative of the World Bank to Ghana, our Honorable Minister of Health, Kwekuwa Agyeman-Aminu, distinguished heads of agencies of the Ministry of Health, the lead health sector development partner, directors of the Ministry of Health and other agencies attached to the ministry, our distinguished virtual participants, our experts, resource persons present, our development partners, here I'm referring to the media, distinguished ladies and gentlemen, permit me to welcome you all to the opening ceremony of the 2023 Health Summit. As we are all aware, this Health Summit is one of the most important events on the calendar of the health sector. The summit provides us a platform annually for us to come together to take stock of the previous year. It also provides us with an opportunity to plan for the ensuing year, as well as account to the people of Ghana. Mr. Chairman, ladies and gentlemen, our theme for this year's summit is sustainable financing for primary health care towards attainment of universal health coverage in Ghana. The role of stakeholders, very important. Such a theme, for me, is apt and clearly outlines our desired intentions of achieving universal health coverage for all people in Ghana, using primary health care as the purposeful vehicle. This aligns directly with our Universal Health Coverage Roadmap 2020-2030, which proposes carefully thought through and innovative strategic interventions, taking cognizance of our current context for health service delivery. We are determined as a ministry to change the narrative around PHC as being poor care for poor people to the ideal of it being smart care for all people. By this, it is heartwarming to note that we are nearing the finalization of our health sector financing strategy, which is proposing that we commit at least 50% of our total health budget to primary health care services in order to fast-track our journey towards attaining UHC for all by 2020. Mr. Chairman, ladies and gentlemen, our distinguished guests, the team also highlights the role of our stakeholders in attaining the UHC goal. This is also firmly grounded in our National Health Policy 2020, which calls for the use of multi-sectoral collaboration as a mechanism for addressing in a comprehensive manner all the social determinants of health. This means that we cannot do it alone as a sector, and that addressing the health sector needs for the people of Ghana will require the support of all our stakeholders. The COVID-19 pandemic response has been a test case to this assertion, and I believe that it is the belief of my minister that the support we receive from our partners and collaborators has been the game changer. Ladies and gentlemen, tomorrow there will be breakout sessions to focus on some critical areas of the team in order to stimulate discussions between us and you, our stakeholders. These may include, but not limited to, the following areas: resource mobilization for PHC, resource allocation for PHC, as well as strategic purchasing for PHC. To this end, let me entreat all of us to heed this call and come to the discussion table with open-minded, where we can take key decisions and strategies in order to improve our health system for a better quality of life for all. It is our hope that all the key decisions and strategies that will culminate in our aid memoir for our next implementing year, which will be the main source of documents to guide our scheme of work. On this note, ladies and gentlemen, our distinguished invited guests, I wish to call on all stakeholders to support the cause of the Ministry of Health, as well as its agencies, as we chart the route towards UHC for all. Mr. Chairman, ladies and gentlemen, on this note, permit me once again, even though our chairman has already done it for us, to thank our development partners who have provided us with various supports to the successful organization of this year's summit. We appreciate your support, and on this note, I welcome you all once again and wish all of us a fruitful deliberations. Thank you.
Thank you very much, Chief Director. Inasmuch as we don't anticipate any danger, it is still prudent that we call on the hotel to give us a few safety tips within just 60 seconds. I'm told we need to have some basic tips. I don't know whether the rep is here. Where is he? The hotel rep? Okay, if he's not coming, it means that we are safe. Thank you. Is he around? All right. So at this point, we still receive some awesome ministration from the Ministry of Health choir. Thank you. Let's do it better for them. A gentle reminder, it is still Health Summit, not Easter Convention. So, but still, if you are touched, you can drop your seed before the General Overseer. I am very sure he'll receive that. Let me welcome the hotel rep to give those safety tips just within 2 minutes to do that. Let's acknowledge him as he comes. Oh, I think for once, Mr. Chair, I'm also taller than somebody. So he'll be projecting, I guess. Do you have it there? Okay. Get systems ready. We will be taking some solidarity messages, so they should stand by for us. The president of CSOs will be giving us a message. The DP lead will be giving us a solidarity message. Same from Parliamentary Select Committee on Health. We'll be doing that as well. So they should all stand by for us as we get ready for this. I shouldn't have released the choir. Are we good? Okay. I think we can proceed whilst you put yourself together, just in order to buy time. At this point, ladies and gentlemen, I humbly want to welcome the president of CSOs in Health to give us a solidarity message. Let's acknowledge him.
Thank you very much, MC. Very good morning to all of our distinguished invited guests. Mr. Chairman, Dr. Anefi Asamoah, the Minister for Health, Honorable Kweku Agyemang-Menu, the Chair for the Parliamentary Select Committee on Health, Honorable Nana Ayew-Efriye, the World Bank Country Director for Ghana, Liberia, and Sierra Leone, Mr. Pierre Laporte, the DP Lead, Foreign Commonwealth and then Development Office, Mrs. Uzomaka Gripping, the Chief Director, Alhaji Hafiz Adam, Directors of the various divisions of the Ministry of Health, the Director General of Ghana Health Service, other distinguished directors here, very distinguished invited guests, and the media. I bring you warm greetings from the Ghana Coalition of NGOs in Health and all CSOs in Health in Ghana. The Health Coalition feels honored for the opportunity to share some few words of solidarity in this August Health Summit. Mr. Chairman, sustainable financing for primary health care towards attainment of universal health coverage in Ghana, role of stakeholders is very timely and resonates with the theme enhancing primary health care approaches towards achieving universal health coverage, as was said by the senior managers meeting held in April this year. I believe the clarion call has resounded more than ever to embrace primary health care as a catalyst to the attainment of universal health coverage. Adequately resourcing the primary health care delivery system in a sustainable manner at the periphery is the way to go as Ghana counts down towards the attainment of universal health coverage in the next 7 years. A theme around primary health care and universal health coverage is the talk of the day within the health space, as the movement towards universal health coverage is now one of the most prominent global health policies, and as such, the needed attention and commitment be given to its realization. Mr. Chairman, primary health care addresses the health needs of all patients at the community level, integrative care, preventive promotion, and health education, but it is noted that this aim overlaps with with that of the universal health coverage, which seeks to ensure access to essential health services and safe, effective, and affordable essential medicines and vaccines for all people, hence require the needed financial commitment and support. Prevention, as stated, is always better, safer, and cheaper than cure. Mr. Chair, undoubtedly, universal health coverage depends on a strong primary health care system which encapsulates on community-based interventions known to be effective, tested, and tried over a period for improving health outcomes. Community involvement in terms of provision of other resources in kind is therefore considered to have the synergistic effects required towards the attainment of universal health coverage. Mr. Chair, distinguished invited guests, universal health coverage is not a dream for the future. It is already a reality in many countries. However, without a sustainable financing and commitment to primary health care interventions, UHC can only remain nothing but a dream for Ghana by 2030. Mr. Chairman, the Honorable Minister for Health, it is worth saying that the Ghana Coalition of NGOs in Health and its networks in health with a vision to have a nation free of disease and ill health has existed to support the primary health care agenda in various communities across the country. Notably among them are demand generation, social mobilization, awareness creation, community sensitizations, advocacy, and other health promotional activities, which have all attracted some financial commitments. Mr. Chairman, as a preventive measure and effort to attain Healthy Ghana status through universal health coverage, the time is now to budget, allocate, and disburse adequate amount for primary health care interventions. And this should not be considered as expenditure, but an investment worthy for consideration. Mr. Chair, Honorable Minister for Health, in order for Ghana to walk the talk in sustainable financing for health care towards attainment of universal health coverage, the capping of the NHIS, which has led to the low funding of NHIS resources at 20% on primary health care, as captured as a bottleneck in the UHC roadmap, should be reconsidered. It's about time Parliament initiates appropriate actions in amending the Act that capped the NHIS for exemption, and I strongly remain hopeful that the chairman for the Parliamentary Select Committee, Honorable Nana Ayu Efriye, would work tirelessly towards this rectification. We further recommend the prompt initiation of high-level advocacy in the establishment of National Emergency Response and Immunization Fund, born out of the 1% COVID-19 levy and the National COVID-19 Trust Fund, as we are made to understand by His Excellency the President that Ghana is free from COVID-19, translating into our local parlance as Ghana bomodin etu COVID asekra. Mr. Chairman, the people of Ghana are now running after us, and what they say is no COVID, no levy. It is about time we reprogram the COVID-19 levy to do something else that will support our health sector. Mr. Chairman, a survey conducted by CSOs in health on immunization services has indicated a shortage in Pfizer COVID-19 vaccines and some childhood routine vaccines, among other commodities in various health facilities across the country. However, under the UHC agenda, sustainable vaccine financing and budget allocation to support Ghana's primary health care program under the UHC roadmap is critical for consideration. And as a proof of the ministry's commitment to sustainably finance primary health care to attain UHC, the general public will be happy to see the aforementioned vaccines in abundance for utilization by eligible populations between 15 to 17 years and children under 5 years, respectively. Mr. Chairman, Honorable Minister for Health, in the quest to attain universal health coverage through the sustainable financing of primary health care, I would like to use this opportunity to seek further clarity on the ambulance found in Dubai, which has gone viral, purported to be one of the 26 ambulance vehicles procured with the support from World Bank. On that note, I want to thank you, Mr. Chair, and a special thanks to the Honorable Minister and his able deputy ministers, the Chief Director, and then we say Ayiko to all of you, and thank you for your leadership and the good work you've done so far. We want to congratulate you, and then also once again say we wish you a very fruitful summit. Thank you.
Thank you. I call on the DP lead, Foreign, Commonwealth and Development Office here in Accra, Mrs. Uzwamaka Gilpin, to also give us a solidarity message. Let's acknowledge her as she comes.
Good morning, Minister of Health, Honorable Kweku Ajimamenu, the chairperson of the summit and prospective General Overseer, Dr. Anafia Somaoba, Chief Director, Ministry of Health, Alhaji Hafiz Adam, Special Guest of Honor, Pierre Laporte, World Bank Country Director for Ghana, Sierra Leone, and Liberia, DG Ghana Health Services, and other heads of agencies of the Ministry of Health, my directors of the Ministry of Health, my fellow development partners, virtual participants, ladies and gentlemen, members of the media, all other protocols observed. On behalf of health sector development partners, thank you for this opportunity to join with your ministry and agencies, Minister of Health, for this year's Health Summit. As all the speakers before me have acknowledged, it is timely. The theme is appropriate and timely. Ghana's achievement of the Sustainable Development Goal 3 is predicated on attainment of universal health coverage. That is, ensuring all Ghanaians have access to needed health services of quality without hardship. Ghana has grasped this challenge, as we all have heard, with a comprehensive UHC roadmap. However, sustainable financing and a sound health financing strategy underpinning it is critical to achieving UHC. The last year has been a difficult year for Ghana, recovering from COVID and the deepening economic crisis. But as a health sector, we've been encouraged by the remarkable resilience shown by the health sector in tackling multiple outbreaks, while also expanding groundbreaking interventions, such as the malaria vaccines for children under 5 years of age, which reducing malaria prevalence from 14.1% in 2019 to 8.6% in 2022. This is a feat that we don't often acknowledge, but it's one we should note. The submission and approval of the World Bank Primary Healthcare Project, another submission of the Pandemic Preparedness Fund, and the submission of the Global Fund GC7 proposal are also opportunities that we see available now to help us in our quest in Ghana. We commend the government for establishing the National Vaccine Institute and continuously strengthening the Food and Drugs Authority. It is our hope that Ghana will be able to produce the majority of its vaccines and essential commodities in the future. We should take note that even as we hear of the suspected anthrax outbreak this week, that animal health vaccines are already produced in Ghana. And we can learn, and we should learn from that experience, build on that, even as we progress work on human vaccines. The IMF program is a welcome development, providing the much-needed stabilization for Ghana's economy and improving sustainability of government financing. However, as many of the economists know, and I'm sure there are many in this room, the tightening of the belt continues. It is far from the answer. And we must continue to make best use of available funds. The commitment within the program to protect social spending, including that of the National Health Assurance Scheme, is commendable. But we'll be lacking in our duty if we don't use this opportunity to make some observations. We must draw your attention to the fact that strictly controlling allocations for goods and service and capex and curtailing wages and hiring could negatively impact the ability of the health sector to effectively address existing gaps and inequities in services. As my colleague has said from the coalition of NGOs, there is no specific mention or protection for vaccine financing, a well-established health best buy for governments, and absolutely critical for cushioning the impacts of health shocks, including in pandemics. We remain deeply concerned about the availability of essential medicines and routine childhood vaccines. These are central to delivery of quality primary health care services, and without them, health workers are placed in a difficult and untenable position. Underpinning the stockout of essential medicine, as well as the availability of co-financing fiscal space for vaccines, FP commodities, malaria, it's the reduced and delayed flow of funds to the NHIS, to the National Health Insurance Scheme, to reimburse healthcare providers, both in the public and private sector. With Ghana spending less than the sub-Saharan average on goods and operations in the health sector, greater protection for the government's health sector budget is required, even in the midst of an economic crisis. Turning to the opportunities ahead, and we have to be hopeful. The 2022 to 2025 Health Sector Medium-Term Development Plan provides the needed strategic direction for making up for health gains lost and striving towards attainment of the SDGs. We will shortly be presented with the report on health sector performance for 2022, and this will form a useful benchmark for us to measure our progress. Not only this, but also a midterm review of the health sector medium-term development plan will also be required in future to ensure us to identify areas to hasten progress towards attainment of UHC. We commend the government, the Ministry of Health and its agencies for the pragmatic effort to reform primary health care service delivery through the network of practice and model health centers. Effective implementation of these initiatives will require innovative financing at the primary health care level and services that it provides at this level, including curative, preventive, and health promotion. So this would mean effective collaboration between service delivery bodies, organizations, and health financing bodies of the sector would equally and necessarily be essential to achieve the stated goals. But most importantly, and one in which we often measure but pay lip service to, is involving communities from their onset. We welcome Ghana's effort in drafting key documents such as the Essential Health Service Package, the Network of Practice Guidelines, and the Model Health Center Guidelines. But key tasks remains. I won't go into all of them, but reconciling with the insurance benefits package and operationalizing the full package, conducting the necessary financial and budgetary implication assessment, and not least, strengthening existing systems are crucial. We also welcome the drafting of patient referral policy. We heard today about the fact that hospitals must be involved in primary health care. This is indeed accurate, and the patient referral policy will guide our interventions in this area. It is remarkably fortunate that with partner support, Ghana has been able to complete a comprehensive set of health sector surveys, many of which we will hear during this 3 days. Not least the demographic and health survey, the public expenditure review, but there are others that you may not know about. Climate change vulnerability assessment, and others in execution, including the non-communicable disease risk factor survey and the primary healthcare service delivery pathway analysis. These present concrete opportunities for evidence-based prioritization of interventions to make the best use of available resources. That is efficiency, effectiveness, and accelerating progress towards health sector objectives. Ghana must seize this opportunity and make bold decisions. We call on Ministry of Health to utilize these surveys and learnings also from the recently concluded Ministry of Health end-of-year review, and obviously from this summit, to inform work plans and budgets for the second half of 2023 and for the 2024 period. The draft health financing strategic plan, which we'll hear, will guide our work as DPs in supporting you as Ghana and as a ministry to actualize a sustainable domestic financing strategy. We note that this is still in draft. It has to be completed so we can move on boldly and concretely. In terms of co-financing, we'd like to congratulate the government for their efforts to make good use of co-financing commitments to Gavi in 2022. But note that the same needs to be done for the Global Fund under the current grant and also under the $238 million proposal that has just been sent up. Without meeting the co-financing commitments, Ghana would lose significant access to grant financing. Co-financing commitments continue and represent a fraction of global health investments in Ghana. And we urge the government to prioritize this. We are, as development partners, committed to work with Ghana to ensure that a viable transition plan. Let us not forget that Ghana is a lower middle income country. A viable transition plan towards sufficiency in supporting the health sector is realized. And finally, I turn to the issue of governance. Greater accountability on sector governance would require periodic reports on effectiveness of governance structures, working groups, reviews, and also the health summit to inform work plan and budgets. We therefore encourage the Ministry to review and revise the existing common management arrangement to reflect the current stakeholder landscape of the sector, particularly the increasing role of civil society and the private sector, and effectively implement this. Knowledge management tools and the use of information technology should also be leveraged to achieve aid effectiveness by aligning all our activities and resources under one plan, one budget, and one reporting principle. We must all ensure that the health sector management processes are fit for purpose and are implementing diligently. Minister, as development partners, we thank you for this opportunity to join with the Ministry of Health, private sector, and all health stakeholders. I hope we will see, before I finish, can I ask all those in the Ministry of Finance to put their hands up? Do we have representatives for the Ministry of Finance today? Okay. Health Minister, we have some work to do. Not all our partners are here on the table on this very, very important issue. And I think we all must work harder to ensure that they feel part of us and they understand their vital role to ensuring that Ghana achieves the health and well-being of all its citizens. We look forward to the results of the holistic assessment and other presentations and vigorous but respectful deliberations. Your success is our success. Please be assured of our continued support and commitment to the health and well-being of Ghanaians. Thank you for your patience in listening to me. I know it's a long speech, but we don't have very many opportunities. And these are important things that we must state and put on record. I wish us all a productive summit. Thank you.
Thank you, Madam, for such a detailed solidarity message. Thank you. I understand that our video is ready for the security tips. Let's just roll it now if it's ready.
You are warmly welcome to the Labadi Beach Hotel. My name is Paul Kateno. I'm here to give a brief on our safety and security measures in the hotel. Labadi Beach Hotel has its own emergency fire pump with a total of 12 fire hydrant points. The emergency fire exits are clearly marked at various points of assembly. In case you hear the sound of the fire alarm for the first time, please stand by. If you hear for the second time, which will be continuous, please evacuate to the nearest assembly point. The assembly point is located directly opposite the spa, which is the beach gardens. We have a complete fire team of investigators, marshals, and first aiders to assist you. The hotel has connected a panic alarm system to the Labadi police station. The hotel has a 24-hour security coverage. A total of 108 CCTV cameras has been installed by the hotel at vantage points for your safety and security. We are 3 minutes drive to the Southern Command of the Ghana Armed Forces, 5 minutes drive to the Trade Fair Fire Station, 3 minutes drive to the La Police Station, and 10 minutes drive to the headquarters of the Ghana Police Service. This makes our hotel the most secured 5-star hotel in Ghana. We are also 5 and 10 minutes drive to the Family Health Hospital and the Police Hospital respectively. We are also signed onto the West African Rescue Association, WARA, to be called upon in case of emergency. The hotel has 3 generators which auto start in 20 seconds.
Hello, my name is Suleimana Abdul Rashid, Deputy Head of Security, Labadi Beach Hotel. Labadi Beach Hotel was awarded the most secure 5-star hotel of the year 2021. We practice what we say we'll do, and we do it well.
We promise you a nice stay with us, and you are warmly welcome to the Labadi Beach Hotel. Akwaba.
Very well. I think the organizer should also give them an invoice. This is small advert and security tips. Anyway, we are safe. Thank you. Distinguished ladies and gentlemen, I equally want to acknowledge the presence of all the directors of the Ministry of Health. Let's acknowledge them, maybe with a round of applause. Let's acknowledge them. We have a huge list here. We have the Director General Ghana Health Service, Dr. Patrick Kumabwaji, also with us. A wave would do. Then the heads of all the agencies under the ministry and the directors as well. Let's acknowledge them all as well. Thank you so much. At this point, we are to take a message from the Parliamentary Select Committee on Health. Honorable Adumaku Kisi, Member of Parliament for Anyaso, is to represent the chair, and we understand he's still on his way coming, so he will join us very soon. Let's get our cultural troupe ready as we prepare to hear from the host of this particular summit. I want to welcome the Ghana Dance Ensemble Cultural Troupe to give us a performance before we hear from the Honorable Minister responsible for health. Understand, if you don't clap for them, they don't perform. That's what they keep saying. Thank you. you. Oh, let's do it for them. You have no idea the amount of energy you need to do this. Let's do it better for them. Thank you. Distinguished ladies and gentlemen, at this point, we would like to call on our special guest of honor to give us his message. No other person but the World Bank Country Director to Ghana, Pierre Laporte. Let's welcome him.
Honorable Kweku Ajaman Manu, Minister of Health and MP for Dorma Central. Honorable Nana Ayu Afriye, MP, Efidwase Asokore and Chairperson of the Parliamentary Select Committee on Health. I understand he's yet to be here for this year. Yeah. Dr. Asamo Abba, Board Chair, National Vaccine Institute, and Chairperson of the occasion. I'm afraid I cannot match your eloquence. Chief Director, Ministry of Health, Mr. Hafiz Edam, heads of agencies of the Ministry of Health, directors of the ministry, colleagues, development partners, president of CSOs in health, ladies and gentlemen. It is indeed my pleasure to be invited to the Health Summit this year, which is the apex of the health sector gathering in Ghana, and I'm honored to have been selected as a guest of honor. On this note, I would like to congratulate the Minister of Health and his indefatigable team for their prompt response to improving the quality of health in Ghana. The COVID-19 pandemic provided us with an example of such proactivity, and Ghana showed that it can be relied on to provide the exemplary leadership in the sub-region. Honorable Minister, ladies and gentlemen, the theme of this summit, sustainable financing for primary health care towards attainment of universal health coverage in Ghana, role of stakeholders, agrees with our shared country partnership framework on health to improve the quality of primary health care and to improve the delivery of basic services, especially in underserved urban areas. Ghana has made notable progress in building human capital, but segments of the population are still being left behind. Service delivery gaps in rural areas are further worsening migration, stress in urban centers. Additionally, inequality in access to basic services among marginalized groups and across regions of the country has impacted economic opportunities. Unfortunately, this includes people with disabilities and those who suffer from mental health concerns that need to be addressed. All the above would require innovative and sustainable financing of primary healthcare system. And meanwhile, the challenges of the health sector are multidimensional and require effective collaboration with key stakeholders, particularly the community. The World Bank, we feel, we've been a great friend to the health sector in Ghana, providing the required technical assistance as well as financial support to accompany the implementation of flagship policies in the health sector. Our great partnership ensured that the needed resources were available for the fight against the COVID-19 pandemic and on time, and helped strengthen national systems for public health preparedness in Ghana. Honorable Minister, I would like to once again congratulate you and the country for the recent approval by the World Bank Board of the $150 million IDA project, as well as the $31 million Global Financing Facility grant for supporting the Primary Healthcare Improvement Program, which is going to help you implement the primary healthcare reforms called the network of practice. Achieving the Sustainable Development Goals targets for the country would require that development financing focus on results and provide the needed flexibility for implementing agencies to invest in cost-effective interventions. We encourage other partners to join Canada, Gavi, and the Foreign Commonwealth and Development Office, the FCDO, who are aiming to co-finance this operation. We also encourage other partners to provide the technical assistance that are much needed to support the government to achieve these sector objectives. Development partners need to join hands also to ensure that the fiduciary capacity of the ministry and its agencies are strengthened to ensure transparent and efficient use of health sector resources. Honorable Minister, ladies and gentlemen, I will bring my work in Ghana, to a close in a few months, and I must say that it's been a blessing for me and to my family to have been in Ghana in the past 4 years. Talk of controversy, I know I've been at the center of some controversies recently, but that's part of the job. I just wish the media would be a bit more frank and honest in the reporting, but like I say, we work for that and we live for that. I have received tremendous support, Minister, from you, and I am grateful for the love of the Ghanaian people. Personally, I think most of you know I'm from Seychelles, working Prempeh was exiled for over 30 years, so I'm really Ghanaian somewhere. Minister, I have enjoyed a great partnership with you and the government of Ghana, particularly colleagues of your ministry and yourself. As I prepare to leave the country soon, I hope that the restoration of the Ghanaian economy to the pre-crisis level will provide the government with the requisite fiscal space to increase investment in health. The World Bank reaffirms its commitment to Ghana as a reliable partner, and we commit to continue to support the country to achieve its sector development goals. I wish you all a successful summit. Thank you.
All right, thank you. We were expecting the Parliamentary Chair on Select Committee on Health. Fortunately, the rep is here. He was engaged with some parliamentary duties. Honorable Adumaku Kisi, Member of Parliament for Nyasotio, is here. We'll give him some 2 minutes to also give us his solidarity message. Let's welcome him.
Thank you very much. Minister for Health, I'm very appreciative of this opportunity and all protocols observed. In fact, I was touched as I sat down and I saw people who trained me in medical school seated. It just shows one key thing, that health really is very dynamic and very dear to any country. And I'm happy that World Bank has given us a pass. And what I mean by that is Ghana is performing very well in the health sector. And I'm happy that it is all of us, our efforts, that has given Ghana this wonderful, as I would say, appreciation by the world in terms of how we've understood health concerns and needs of our very vulnerable people. And I think this audience is not an audience to reiterate the need for health care. As for us over here, we're very much endowed with that knowledge. But I'm very happy that we're all here to, one, make that key, firm commitment again to helping those in need of health care at the very doorstep of the ordinary Ghanaian. And I would encourage you all, in the words of the chairman for the Select Committee on Health, to be bold and to continue steadfastly in all your various workings. And I would also commend the media, which is a very, very now important part of the work we do in terms of reaching out to many more people. And to our World Bank leader who's leaving soon, Laporte. Our only key word from you for Ghana is that you're always welcome back to continue the good work and to also be an advocate for Ghana wherever you find yourself, so that Ghana will continue to stay with you, and wherever you go, do keep us in mind. So on that note, thanks for this opportunity, and I'm here with the words from Dr. Ayu, who's the Select Committee, Ayu Efrie, who's the Select Committee Chairman, and to encourage all of us to continue steadfastly. We've done well so far, but there's many more work to do in the future. Medamunra Ase. Thank you very much.
Thank you, Honorable, for making it very brief for us as well. Let me acknowledge some of our sponsors. We have UNFPA, we have UNICEF, World Vision, USAID, World Bank, Gavi, WHO, Farm Access Foundation. Let's acknowledge them with a round of applause for sponsoring this particular program. We are most grateful. At this point, ladies and gentlemen, it is time for the host to speak. And it is no other person but your minister, my minister, our minister, Honorable Kweku Agyeman Menu, Minister responsible for health.
Thank you very much, Naftali. The titles the chairman was talking about are still here, but I refuse to mention some of the titles as well. But I don't have any option. So I have to address Dr. Chairman and Board Chair for the National Vaccine Institute, Dr. Samuel Ba. As for the professional titles, it's only the accountants who are not using accountant Agyeman Menu, accountant Dignitary. But we have the doctors. Now everybody is a doctor, including even procurement officers and everybody. And then we have the engineers, engineers, Afumafu, everybody who has that title. And then the professors, Professor Ampofu, Professor this, and all that. So the titles will continue to be with us, and we add more as and when we develop new professions. Excellencies, members of the Diplomatic Corps, colleague MPs, I understand. It looks like Dr. Kisi, you are the only one here with us today. The chairman sought permission. I've addressed the chair already of the Parliamentary Select Committee, the chief director, the ministry, agency heads, health sector lead, and all our development partners present. I'm with directors and directors of all our agencies present, experts and resource persons present, distinguished virtual participants. I understand there are many of you, fellow health workers across the country, our media friends, distinguished ladies and gentlemen. Once again, we have gathered here to review our performance and redefine our health priorities for the next program of work for the sector. I shouldn't have been here, but after I tested negative for COVID 2 days ago, I gathered courage to join. And I just came to add my voice to also welcome our sponsors, partners, agencies, and health workers across the country for this all-important summit, the life of the sector, at least once a year. Indeed, your individual and collective contributions have brought us thus far in fulfilling our mandate as a sector ministry. Let me, on behalf of the government, express our special thanks first to the World Bank Country Director and his team for the massive support they gave us during our COVID experience. You're talking about timely delivery of resources to do work. And the first amount of money we got was good through the efforts of the World Bank led by Pierre. We wouldn't forget the Minister for Finance and the Parliamentary Select Committee. And they continue supporting us in terms of our resource mobilization efforts. And not very long ago, the country director mentioned it. The Finance Ministry, Parliamentary Select Committee, the ministry itself have gone through to be able to secure some loans approved by Parliament for the sector. These funds will greatly help to address the myriad of challenges facing the health sector post the COVID-19 pandemic, and more specifically, some good amount to help us actually implement our network of practice that the chairman is advising that we shouldn't cut it off to the health centers, but see how we can extend to join with the hospitals. I think that is good advice, Dr. Chair. We will look at it. Dr. Chair, ladies and gentlemen, in fact, the health sector needs more strategic funding to assure the quality of life of our citizens, as well as ensure we have a better response and resilient health sector in the country. The year 2022 has been very challenging due to our current economic crisis. Despite economic challenges, the health sector remained relatively stable in terms of our interventions and corresponding outputs, outcomes, and impacts. We have actually been put to test, but through what we did with COVID, in the process, we have fought and won how many outbreaks? These were mentioned, from Lassa, monkeypox, measles, yellow fever, Marburg, whatever. And we did that within a very short, reasonable time. And it looks like our response is now a bit strengthened, and we are ready to look at what it is as we prepare to look at what emergency response strategies we can adopt facing the next things that we can see in our country. And Dr. Chair, when you were grading us, you didn't count our votes from outside. How the world now sees the efforts that Ghana is making in health. So if you add that one, we will get to A. Dr. Waji has been attending the WHO Executive Board meetings. We will remember until last week. And about a year now, I haven't been able to go. He represents us. And he hears what is there. In the last World Health Summit, those who attended can attest to the fact that we have gained some very good respect within the global health architecture. And we thank our president, the World Bank, and all our donors, especially those who have been consistent with us, our Global Fund and Gavi, over the years. 2022 saw a decline in the institutional maternal mortality ratio from 119.6 in 2021 to 102.6 in 2022. This, I understand, is very commendable. However, two regions, or three, Ashanti, Greater Accra, Eastern, these regions recorded high maternal mortality ratios. Now, I think there is the urgent need to support these regions to address the possible contributory factors. Institutional stillbirths, neonatal, infant, and other 5 mortalities also reduced marginally in 2022. Family planning accepted rates also saw an increase from 33.8% in 2021 to 36.1% in 2022. Our region recorded the highest family planning accepted rates among the regions, and so they need to be commended. The regional director for Ahafo, let us clap for them. You've done so much. And I'll bring UNDP to see what you are doing there that can be extrapolated and that to be done somewhere else. These modest achievements, among others, are quite commendable, but we really need to do more to continue to justify for more funds. Distinguished ladies and gentlemen, I wish to reiterate that the government of Ghana is committed to achieving universal health coverage and increasing access to essential health services by 2020 and beyond. We believe that this commitment can be achieved through strategic investments in primary healthcare. Ghana remains significantly below the lower middle income countries' average allocation of 2.3% of GDP. When we draw our international comparison with other lower middle income countries, based on observed data from the WHO Global Health Expenditure Database. However, the proportion of the overall budget contributed by the government for the health sector has remained relatively stable since 2017, hovering between 59% and 62%, except in 2021, where it reached 64%. But you understand the reason why that was part of the heights of COVID investments. Donor funding has, however, been less stable. It reached 17% of the total budget for the health sector in 2017, but fell to just 6% of the budget in 2020, after which it rebounded to 12% again in 2022. That also has a reason. And I must emphasize and say that donor funding in the ministry now is so much so dry, virtually 0%. But when you get to agencies, we see some efforts being done by our donors. I think as we enhance and try to strengthen our efforts in domestic resource mobilization, though I know that donors are fatigued, but I think to help us achieve what we want to achieve by 2020, we may need some extra enhancement of their support to let us make sure that policies and certain legislations and things that we need to do to facilitate our implementing agencies are also quite in place. It is also important to highlight that the contribution from the annual budget funding amount of the overall health budget has also fallen from 1.2% in 2017 to just 0.3% in 2022. This is even recorded by UNICEF Health Budget Brief 2022. The theme for this year's Health Summit, Sustainable Financing for Primary Healthcare towards the attainment of universal health coverage, the role of stakeholders, is aimed at drawing the attention of government and all Ghanaians about the need to increase investments in primary healthcare management. Sustainable primary healthcare is a key component of all high-performing health systems, an essential foundation for universal health coverage, and a prerequisite for meeting the Sustainable Development Goals. It is a pathway to achieving good health at low cost by providing essential and cost-effective health interventions, including health promotion, maternal, newborn, and child health care, palliative care, immunization, and treatment of common illnesses across the life course. As the global burden of non-communicable diseases increases, primary health care is emerging as a locus of both prevention and the coordination of lifelong management of chronic conditions. PHC also has an important role in providing essential public health functions including responding to epidemic diseases such as the COVID-19 pandemic. When successfully delivered, primary health care serves as a key vehicle for fulfilling governmental and societal commitments. For example, primary health care expansion improves equity when its services reach vulnerable segments of the population. Because primary health care services are provided where people live and work, and because primary health care focuses on population health, it can address many determinants of health that underpin various sources of vulnerability. PHC can protect households' financial well-being by fostering good health and reducing the risks of diseases among breadwinners, caregivers, and other family members, and by averting the need for expensive secondary and tertiary health care. I don't come from a very rural area, but I have a very large portion of my constituency living in what I would describe as cottages. There are some in there who will never move beyond a primary health care facility. Even on referral to a district hospital, at times it's a challenge. So there is a need for us to see the primary care level, the least level, what services they provide, and how useful this is if you're actually implementing a roadmap towards universal health coverage. Despite periodic attempts to refocus on primary health care, vertical programs, hospital-based and specialist-based care models have regularly been prioritized over primary health care. Funding for PHC has generally been insufficient, and access to primary health care services remains inequitable. Services are of inadequate quality, and patients often have to make out-of-pocket payments in some instances to actually use or access these services. Healthcare worker shortages persist, particularly in the rural areas, where the need is often greatest. And in many countries, supplies of medicines, equipment, and other necessary commodities are grossly inadequate. In our case, for example, we have produced a great number of nurses and midwives, but it has become clear that we just cannot, and I repeat, we just cannot absorb all of them. In the process, we are losing experienced ones to the developed countries, while at the same time, we experience unequal distribution of health workforce in the country. The work we started doing to address the challenge of inequitable distribution of our health workforce has come to a standstill after the consultant presented. And it's like almost all they put in there were incentive-based type of packages to drive people to the hard-to-reach areas. I encountered a young medical officer in the Sunyani Regional Hospital, and I started chatting him up. And out of my enthusiasm, trying to be a consultant, doing some survey, I asked him, what will motivate you to stay beyond Sunyani to provide services? So, Minister, what do you want 2,000 keke kra kan yesika ho a yebeko ekrase? That was an incentive package. He never mentioned, Minister, Mama me promotion team. And I'm much time I make answer and I'm a specialist. No, so kakrama mia meko ekrase. No. Then I asked him back, so how many were graduated who have finished to come to do what you are doing here? And the numbers now, the HR directors will tell you. They are churning out over 800 new doctors a year. So 2 years, 1,006, multiplied by, 2,000 per month, so by 12 months. And the finance minister will tell you, this funding, even if you can do for 1 year, will never be sustainable, based on what resources we have at our disposal. So we have to look elsewhere to do some of these things to address unequal distribution of our health workers. Those who are leaving, we are begging them not to leave. I unilaterally suspended clearance forms. I've got petitions from the big associations. Minister, sell the forms. Yesterday, I got a letter from National Security about how some of us are also using the advantage to extort monies from people who are seriously looking for these forms. So I've asked the Chief Rater that let us drop that and let us get the forms out. So a lot more will begin to go. On the last count, was it Pantine also? About how many? Close to about 120 something have left unceremoniously for greener pastures. We are working to try to manage this migration, but some of our young people don't seem to have patience. And the information we have is that the migration they are undertaking is also not the best. So why don't you wait for us to engage bilaterally so that some can go? We have consistently over the last 5 or 6 years been recruiting wholesale all nurses and midwives who pass their exams and get through the professional, PIN numbers, through the magnanimity of the finance ministry, and then allocation of financial clearance to clear them. But we still have a number that is huge sitting at home. Then I keep on asking myself, is this sustainable? So what strategy are we going to use? Close down the schools and stop training? That is not an option at all for anybody. So the only good thing that we can do is through managed, very seriously managed migration, such that we can let a few go and keep a lot more here to satisfy the type of needs that we also have. But these are issues that we are working on. Dr. Chair, ladies and gentlemen, to successfully provide primary health care at community level, national and local health systems need to be reimagined and restructured, beginning with placing the needs and preferences of people, including the intended users and providers, at the center of the system design. This is exactly what Ghana is doing, with emphasis on close to client-centered care through our CHIPS flagship program. We are further strengthening the PhD level with a new thinking network of practice where health centers become the hub and other facilities below it as spokes. We are going to try to modify this part of that principle, that policy we are going to embark upon. Dr. Chair, sustainable health financing arrangements provide the fuel for health systems and the functional PhD programs. They establish the amount of resourcing available and the way in which risks are shared among those who are ill and those who are well. The ways that funds flow through the system to frontline providers and the payment system that creates incentives for providers. Together, these arrangements shape the equity, effectiveness, and efficiency of PHC. In this regard, one of the key resource mobilization drives should be focusing more on domestic resources. This space has a lot of low-hanging fruits we can tap to finance our primary health care. We need to strategically engage local business entities who have well-structured corporate social responsibility schemes to support our healthcare system. Similarly, we must strengthen our collaboration with other MMDAs under the Health in All Policies principle to mobilize resources to address issues hindering the delivery of PHC in line with our national health policy. Sustainable health financing arrangements provide the fuel for health systems and the functional PHC programs, as I said earlier. In this regard, we must continue to strengthen our collaboration, as I've just mentioned. As we discuss the sustainability health financing arrangements for primary health care, it is important to also address the following questions. How do we mobilize sufficient resources to support PHC objectives? How do we ensure that resources reach frontline providers in ways that align with PHC objectives? And how do we design financial incentives that encourages the delivery of access to high quality, equitable, integrated, and efficient PHC? And how should PHC be centered on people and focused on equity? Having said this, I am very hopeful that this summit will provide concrete policy options for a sustainable funding for PHC in the attainment of our universal health coverage for Ghana. Before I finish, finally, I think you join me to continue to express our appreciation. And thank you so much to Pierre, who has just announced his exit in the next few months. Pierre, is that correct? But you and me, I know we will meet, if anything at all, on the rooftop before you go. But I believe wherever you go, Ghana will be a country you will never easily forget. You've made good friends here through civil society, partners, development partners, our directors, and several of them even below, health workers, governance systems, parliamentarians, almost everybody, Pierre. And your name sounds across almost everywhere that you go. And we know we are not working for only this ministry. You've done so much for us. But me, I don't know how I can easily forget you with what you did for us during COVID. And even now, you continue to support our efforts as we go forward. So we thank you so much. But we will meet again before you leave here. Honorable Chair, I think at this stage I don't have anything else to say than to wish us all very fruitful deliberations and a successful summit. I thank you.
Thank you very much, Honorable Member of Parliament for Doma Central and Minister for Health. We've been sitting for almost 2.5 hours now. It is obvious that at this point, it will also be appropriate to call for a coffee break. The choir will give us some ministration whilst we get ready for our coffee break. And the announcement is that people on the high table will be ushered to the lounge to have their coffee there. The rest of us are moving to the Omani Gardens. I'm told it's just right behind us to have our coffee. And it's only 30 minutes. The business of the day is quite lengthy, so it's only 30 minutes. But those on the high table would also move down. Let's have a group photograph before we can go for our break. So the photographers, please help us. Choir, are we ready for this? Okay. The directors stand by to join them. Directors of the ministry, please join them. Directors of the ministry, please join them. Heads of various agencies, please join. CEOs and heads of various agencies, please join them. Some can move upstairs. Some can move upstairs. Ushers, please help us. Let's usher our dignitaries to their lunch. Let's usher our dignitaries to their lunch to have their coffee. The Minister, Director General would all be available for interviews. All right, thank you. Thank you. Are you ready? Wait. Are you ready? Are you ready for your interview, America? Wow. Thank you, Amwechkwa. We need more from you, so please go and have snacks and come back, because we need more from you. The Minister, Director General, and all others will be available for the interviews at this point. right. Can I please have your attention as we call the next session to order? We've done so well. We've left just within the 30 minutes as anticipated. Can we please resume our seats now as we make progress? We have gotten to a very important point at this time. It is time to hear the year in review, a presentation of the 2022 Holistic Assessment Report. It is no other person, ladies and gentlemen, but a man who has had 20 years of working knowledge and understanding of the Ghanaian health system, and over 10 years of professional experience in health system research and consultancy. At present, he is the head for monitoring and evaluation of the Ministry of Health in Ghana. And prior to assuming this position, he worked as the senior manager for policy of the Ghana National Health Insurance Authority. He serves as a reviewer for scientific journals, including British Medical Journal, BMC Journal, PLOS Journal, and Global Journal of Health Sciences. He obtained his PhD in public health from University of Ghana and has authored a book, chapter, and several peer review articles and conference papers on health financing and health policy evaluation. Ladies and gentlemen, help me welcome Dr. Eric Nsia Boateng, head M&E Ministry of Health, to do this for us.
Okay, good morning. Okay, good afternoon, everyone. And thank you, Mr. MC, for that introduction. So I think it's time now for us to look at the performance of the sector in the year 2020. It's one of the main reasons why we've gathered here to assess the performance of the sector and then take discussions and key issues out of it. So in the next 60 minutes or 1 hour, we will all go through the assessment that we did together with our agencies and show you the performance for the year, and then we come to the plenary to discuss that. I do this presentation on behalf of the Director PPME, Mrs. Emma Ofori Ajiman. Thank you. So we look at the holistic assessment process, how we assess the health sector, and also take attention onto the sector performance by the objectives. We have 3 policy objectives in our medium-term development plan 2022 to 2025. And then in doing this assessment, we encountered some challenges we want to share with you so that together we find solutions to them, and then in the next year we overcome them. Then we go into the conclusions to know where we stand with respect to this assessment for the year 2022. So as we all know, the holistic assessment is a sector-wide assessment of all the issues that we deal with in the sector. For example, the program of work, the health plans of the agencies of the ministry. And because of that, we derive the scoring and all the assessment from the program of works of the 2022-2025 medium-term plan. We also made sure that the other assessment of the agencies of the ministry and then the budget management centers at the community and district levels are also fed into all these assessments. So if you look at it, it's a bottom-up approach from the community up to the national level. So normally we wait for all the agencies to conduct their performance assessment, which we also take part in this assessment. And then we come to the ultimate, which is the health summit, where we assess the entire health sector and provide the findings for discussion at this forum. So for this year's assessment, because we have a new medium-term plan, we needed to go back and revise the assessment too. The one that we used for 2018 to 2021 had about 4 policy indicators. The new medium-term plan has 3 policy indicators. So we needed to go back and revise the assessment to conform with the objectives that we have. And we selected technical working group from the agencies and the DPs, and then the academia to assist us to revise the 2. So we use that to conduct this year's the assessment for the year 2022. And the 2 also considered the policy objectives in the medium-term plan. The first one is about access to health services. The second policy objective is about how do we reduce the maternal and child deaths and improve adolescent health. And the last one talks about the clinical and public health emergencies. How do we improve access to all those areas? So we have indicators for all these 3 policy objectives, key indicators. If you look at our medium-term plan, we have a lot of the indicators. But in doing this particular assessment, the technical working group selected key indicators that we believe will be of most importance to the gathering. And that is what we will present to you. So if you take the main report, you may see a lot of indicators that may not be presented here, because our focus is to look at the outcome and impact indicators for discussion. So in doing the assessment, what we did was that when we look out for the baseline for the year that we are doing the assessment, which is 2022, and the target that we set for ourselves, which is also 2022. Then in the assessment year, we look at the performance score and then relate the performance score to the target to see whether we achieved the target or we exceeded the target or we missed the target. But we also went further to relate it to the baseline, because you may miss your target but did well or perform if you compare your performance to the baseline. So when we did all that, we decided to place this on a scale. We had about 7 scenarios. We'll get to it very soon. So we placed this on a 7-point scale from -3 to +3 with qualitative interpretations. So for example, if an indicator score -3, we give interpretation of poor. Up to a +3, we give interpretation of excellent. So this is the algorithm that was used to do the assessment. So for each of the indicators under the 3 policy objectives, we asked certain questions to arrive at the score. So the first one, we asked whether data was available to assess that particular indicator. If no, you see the red on the far right, we give you -3. It means that there was no data for us to assess that particular indicator. If yes, you turn to left and we ask further questions. Compared to target, how did performance change? And then if you look at the right hand, compared to baseline, how did performance change? So based on these scenarios, we arrive at 7 exclusive scenarios. So for the first one, the indicator, the performance of that indicator may exceed the target. And once it has exceeded the target, it means that you've also exceeded your baseline. So that becomes a score of 3, and we give an interpretation of excellent. The second scenario is where the target is met, and then compared to baseline 2, you've also increased on the baseline, or there was no data available for that assessment, we give a score of 2, and the interpretation is very good. The third scenario is where the target is also met, but compared to baseline, you didn't improve on the baseline. There was a stagnation. So we give interpretation of good with a score of 1. The color is light green, as you can see from the screen. There's another scenario where you may miss your target that you set for the year, but compared to the baseline, you did better, you increased on the baseline, or there was no data to assess that indicator. We give you fairly good performance with a score of 0. The other scenario we also saw was that you missed your target for the year and then stagnated compared to baseline. Then we give you a score of -1, and the interpretation will be an average score. The C scenario is that the target was missed for that particular indicator, and also compared to the baseline, there was a decline in the baseline. You didn't improve on your baseline. So it means that it's a below average performance, and a score of -2 is given for that indicator. The last one is what I pointed to earlier, that if there was no indicator for us to assess, no data for us to assess that indicator, then obviously we give a score of -3 and an interpretation of poor. So this is how the assessment 2 was done. When the committee finished its work, we automated the system. So as you can see from the screen, forgive me, it's quite small, but this is a snapshot of the assessment 2 for the ministry based on the medium-term plan for the next 4 years. So you have all your indicators here, the baseline, target, and then the performance for the year that we are doing the assessment. So once you put in all the indicators for a particular objective, in this case, policy objective 1, then we have our baselines that we set. We enter the target that we wanted to achieve. And then based on the assessment, we put in the scores, and everything will be populated up to the far right, where you have the scores and the interpretations. So this is the snapshot of the tool that we use to do the assessment. So for our policy objective 1, which is mainly focusing on access to health services, we selected key indicators. In fact, in all, we had about 60 indicators. But during the assessment, we only got data for 50 of them. So 10 of the indicators, either they are survey indicators that we need, a survey to be conducted before we get the data to do the assessment. So in this particular assessment, we use 50 indicators for the 3 policy objectives. So for the policy objective 1, some of the key indicators that we used to measure access was the average number of medicines that we prescribe, nurses to population ratio, doctor to population ratio, percentage of facilities that are in good standing with HEFRA, the doctor to population ratio, NHIS coverage, which is financial access, and out of pocket. So the green ones are the ones that we exceeded the target that we set for ourselves. The yellow ones are the ones that we missed the target, but we improve on the baseline. The red ones are the ones we refer to as the below average. We missed the target and maybe stagnated based on or compared to baseline. The dark red, as you can see, the -3 are the indicators that we did not get data to do the assessment. For example, out-of-pocket expenditure as a percentage of current health expenditure. These are the things that we need to do household survey and get the data to do the analysis for that. So based on all this, the overall score for this particular objective is -2, which is below average. And the overall score was obtained by taking the median score of all the scores for the indicators. So even though we didn't get data for some of the indicators, we did not throw them away because we believe that it is our duty to make sure going forward we get data for these indicators and include them. So we did not throw them away just to let us know how we are faring in terms of data generation data quality, access, and all those things. So here we are going to take a look at some of the key indicators for Objective 1. As I mentioned earlier, in the main report, we have other indicators that may not be in this presentation. So here we are looking at the number of outpatient visits by facilities type and ownership. In all, we had about 34 million facility visits. And if you look at the decomposition, we had majority of these visits going to the district hospitals, and very few of them going to the teaching and the other hospitals like the university hospitals, psychiatric hospitals, and the regional hospitals. And this is obvious. I mean, it's not surprising because if you look at OPD service, mainly at the primary care level, and that is where we have a lot of the population going for services. So based on this, majority of the utilization happen at the district hospitals, recording close to 45%. If you further disaggregate this data by ownership, ownership here means the type of the facility. Is it a government facility or a CHAG or other faith-based facilities? And from here, you can also see that about almost 60% of these visits happen at the government facilities. CHAG is around 17%, the same as the private facilities, and others are recording less than 10%. So this is just a general overview of the OPD visit to our facilities in 2022. Now, if you look at visit per person per year, the outpatient visit per capita, as you can see from the trend, there was a marginal improvement or increase from roughly one visit per person per year in 2021 to the same one visit per person per year in 2022. So that is what this graph is telling us. It's also giving us an indication that the health-seeking behavior, as we all expect, may not be encouraging. If one person is making a visit per year, I think we all agree that that may not be encouraging. It means that we may have so many people at home having certain health conditions who are not reporting to the health facilities for treatment or assessment. We decided to disaggregate this data by the administrative regions that we have in the country. And you could see that in the northern part of the country, the ones with the red color, recorded very low outpatient visit per person per year. And it's also clear to us that access to certain resources like human resource, the health professionals and facilities, as we all know in the northern part of the country, may not be as good as compared to the urban centers. Interestingly, in the western north, the visit per person per year was very high. That was close to 2 visits per person per year. And we need to interrogate this further, maybe in the plenary session, to find out from our experts here what really is happening in the western region. Western north, sorry. Then, budget allocation to the health sector. We also decided to look at the allocation of the budget to the health sector over the last 5 years. And as you can see from the screen, in 2020, that is where we had the highest of about 9% of total government budget being given to the health sector. In 2021, I'm sure it's also partly because of the COVID, there was a dip to 6.6 or 7%. But last year, 2022, this negative trend was reversed, and now we have close to 7% of total budget being allocated to the health sector. Once again, we decided to look at the per capita spending or health spending per person per year. And you could see that it's also moving up. If you compare 2022 figure, which is around 341 or 42 Ghana cedi, in dollar terms, it's around $40 per person per year that the budget or the government spend on each person in this country. It was more than or close to double compared to the previous year, 2021, which was 276 Ghana cedis, or around $24 per person per year. In fact, these figures are very low if you compare to the sub-Saharan average of around 70 or a little over $70 being spent on one person per year. So it tells you that we still have a long way to go in terms of financial resources to the sector to improve health outcomes. The NHIS population coverage, in fact, they targeted to register around 18 million people, but they got to 17.2 million, representing 54.5% of the population with active NHIS cards. This is just a marginal increase if you compare to the year 2021. But the good story is that over the last 5 years, there has been that consistent increase in terms of the active or the population registering into the scheme. So here we decided to also do further analysis to know which of the administrative regions that we have a lot of people enrolling in the scheme. And we saw that if you take the Bono and Ahafo area, they are recording from or above 70%. The same applies to Upper West and Upper East. Unfortunately, if you look at the central region, Greater Accra, Northern, and OT, the coverages over there are very low. For instance, if you take OT, last year it was the same, and because access to services over there is also limited, access to healthcare facilities, regional hospitals and others, access to health professionals are all limited. In addition to that, there are also barriers in trying to register into the scheme. Some may have to cross with a boat to the adjoining villages or districts to be able to register. So all these things contribute to these factors. But one striking thing that is emerging from this table is that the urban centers like Greater Accra and Ashanti are recording low coverages, which may suggest that maybe out-of-pocket payment and other things may contribute to this. But the experts are here for us to listen and discuss the issues. But generally, this is the trend in terms of population coverage across the 16 regions. With respect to the releases from the Ministry of Finance to the NHIA to pay claims and also undertake other administrative activities, we saw that the orange line, as you can see, is the amount that were released to the NHIA in each year over the last 5 years. So here, around 2020, I think they had the highest releases of close to 2.2 billion Ghana cedis. And then 2021, this came down, which I believe that it may be due to the COVID issues that they needed money to also pay for claims that were coming to them. 2021, the releases came down to 1.4 billion cedis, Ghana cedis. And the year under assessment, it went up to 2 billion cedis. So in the year 2022, the NHIA received a total of 2 billion Ghana cedis from the Ministry of Finance. The top blue line represents the budget, approved budget over the last 5 years. And in the year under review, the approved budget was 2.69 Ghana cedis. When we look at the share of the releases that was used to pay claims, provider claims, you could see that over the last 5 years, there has been a decline from 63% of the total releases to about 60% as we speak today, which represents the year 2020. So in 2020, 60% of the releases in that year was used to pay provider claims. We also look at the density of doctors to population in our country. And we saw that, unfortunately, in the year under assessment, there was a decline. This is per 1,000 population. If you convert it into 10,000 population, it means that a doctor is serving about 500 population in Ghana. 2021 was the highest, but before 2021 the figures were not looking good, but there was a consistent increase to that. In fact, if you look at the absolute numbers in the GOG budget, those on government payroll, the doctors are a little over 5,400. And this reduced to 5,300 in the year 2022. And I'm sure that is what translated into the doctor to population density as we are seeing for the year under assessment. So the message here is that as we speak today, one doctor in Ghana is serving around a little over 5,000 people. And this is also below the global target of one doctor serving a population of 1,000. We decided to look at the regional disaggregation, and we saw that in the Ashanti region, Bono and Greater Accra, the doctor to population ratio looks very good compared to the other regions. And this is not surprising because of the distribution of the personnel across the country. We have most of them concentrated in the urban centers and then few others in the rural areas. So you see in the northern part of the country, we have fewer doctors serving more population in that part of the country. The nurse to population ratio per 1,000 population was very encouraging. We recorded close to 2 nurses serving a population of 1,000. And if you compare this to the global target, it means that we've achieved the target of 1 nurse serving a population of 1,000. And this has been consistent from the last 5 years, 2018 to 2022. In terms of the regional breakdown, the Ahafo region recorded the highest of about 3 nurses serving a population of 1,000 in the region. But the worst performance was recorded in Northeast, where 1 nurse will be serving a population of 1,000, but it's still higher than the global target of 1 nurse per 1,000 population. So those are the key indicators that we decided to consider for policy objective 1, which is access to health services. Policy objective 2 in our medium-term plan focuses on how do we reduce the maternal and child deaths and also improve on adolescent health and disabilities. So here, the technical committee also selected key indicators to do the assessment. And if you look at the screen, some of the indicators that we considered were midwife to wafer ratio, that is women in fertility age, the antenatal visit or coverage, at least 4 visits, the stillbirth rate, number of children immunized, the neonatal mortality rate, and then under 5. So these are some of the things that we considered. And here, once again, we perform well with some of these indicators I've mentioned, a score of +3. The others that we missed the targets include, for example, the midwife to wafer population, the prevalence of stunting among children under 5 years, and then under 5 mortality rate, the infant mortality rate, and then adolescent pregnancy rate. These are some of the indicators that we missed the target that we set for ourselves. That's why we are seeing a score of 0 with a color of yellow, meaning that we had a fairly good performance. So we turn our attention to look at the trend analysis of some of these key indicators for objective 2. With respect to the antenatal visit and then skill delivery and postnatal care, for the year under review, there was a general decline in all these indicators that we consider based on the target that we set for ourselves. So we were doing, for example, if you take the antenatal care +1 visit, we were doing around 70%, which is also good. And then if you take the green one, which is skill delivery, we're doing a little over 50% coverage for that. So attendance by skill personnel was around that. When we disaggregate this data by the administrative regions, we saw that in the Northeast, Northern, Upper East, and Upper West regions, we recorded high coverages for skill delivery. Unfortunately, in the Greater Accra and Eastern region, the coverages are very low, around 59 or almost 60, and then 51%. We also look at the maternal mortality, which is one of the SDG indicators, per 100,000 live births. And from the data that we use for the assessment, this is an institutional data. We are doing around 102 deaths per 100,000 live births. And if you look at the trend over the last 5 years, it declined from 128 in 2018 to about 109 in 2020. And then a jump came in 2021, close to 120 deaths per 100,000 live births. So if you look at the global target of at least 70 deaths per 100,000 live births, with this institutional data, we can say we are far behind. But if you look at the survey from the Ghana Statistical Service, the 2022 Demographic and Health Survey, I think we are doing better, which will be presented later in the day so that we look at the deaths from the communities as reported in the survey. So this is about the regional breakdown, and Ahafo, once again, is also doing well with respect to maternal deaths. It's going down. The North compared to other regions. In Northeast is the same thing. The OT is the same thing. But the caveat here is that if you take OT, for example, because they don't have regional hospitals and other health facilities, some of these things the deaths may be recorded outside the region, in adjoining, facilities outside the region. So access to, as I mentioned earlier, to the OT region, respect to professionals and facilities, is not high compared to other regions. So you may have 5.2 deaths, but the issue may be that some deaths are being recorded or reported at homes, not in the facility. So they are not captured in this database. So we need to be careful not to be jubilating that in OT region, the maternal deaths is as low as 5 per 100,000 live births. The stillbirth, neonatal and infant under 5 mortality, we also decided to look at the trend in this. And the good news is that in the year-end assessment, all these key indicators had declined in the deaths reported to our facilities. So, for example, if you take the under 5 mortality, which is the yellow one, we recorded around, I think, less than 12 deaths per 1,000 population under 5. The regional disaggregation by neonatal, we are picking neonatal because it's one of the SDG indicators. So if you look at this before the first month, the 28 days, for the for the Ashanti region, it's also quite high. It's around 6 point, almost 8 deaths per 1,000. And then if you look at the Greater Accra, it's also quite high. In fact, it's the highest compared to the other regions, recording 10 deaths per 1,000 live births for children below the 28 days of birth. Where we had very good performances are in the Northeast region and then in the OT and Savannah region. The under 5 mortality, which is also one of the SDG indicators, with respect to the regional breakdown, we had that the Ahafo and Ashanti also doing very well. And then the Greater Accra, Eastern, Northeast, and other regions, Northern region, recording close to or between 10 to 15 deaths per 1,000 live births. And the Western North also recorded a very high performance of close to 5 deaths per 1,000 live births for the under 5-year-old. So all this will be discussed thoroughly during the plenary session. With respect to the midwife per 1,000 women in fertility age, that is also going up. So we have more midwives attending to the population who need maternal health services. If you look at the year under review, we have close to 3 midwives attending to about 1,000 population in the country. There has been a consistent increase, as you can see from the chart, from about 1 to 3 as we speak today. With respect to the regional disaggregation, I think where we recorded the lowest is in the Northeast, where we have about 2 midwives attending to a population of 1,000 women in fertility age. The highest was recorded in the Upper West. That's around 4.28, so close to 4 midwives in that region attending to 1,000 women in fertility age. The underweight is also one of the SDG indicators, and we decided to also assess it and look at how we are performing with respect to that. And we could see over the last 5 years that there has been a decline, or if you like, an improvement in this particular indicator from 3.1 in terms of prevalence for the other 5 children who are having underweight conditions to close to about 1.5% of that target group. The adolescent pregnancy is also one of the SDGs, and here we have 2 components. Those between the age of 10 to 14, which normally they refer to them as girls, and those who between 15 to 19, which we refer to them as, in other reports, as women or adolescents. But the overall from 10 to 15, there was a marginal decline from close to 33% of that population being pregnant in 2021 to about 30% of that target group of recording pregnancies within that group. The same applies to those aged between 15 and 19, a very marginal decline from 16% of that target group to 15%. And then the girls, as I refer to, is seen in other reports between the age of 10 and 14, also recorded a marginal decline. So in all, with respect to this particular indicator, there is a decline in terms of adolescent pregnancies in the country. In the regions, we have high percentages in the Bono East, where those aged between 10 to 19 are recording high pregnancies, and then Greater Accra recorded the lowest or an improved adolescents who are getting pregnant. This is around 7% per that target group between 10 and 19. So the last policy objective in the medium-term plan focuses on access to clinical and public health emergencies. So here we also selected key indicators to assess this particular objective. But in overall, we perform fairly good with all the scores that we have here. Some of these indicators that we look at okay, forgive me, I think that is not the slide. But we look at the average response time to emergencies. We also look at the blood collection index and other indicators. So in terms of the trend analysis, with respect to the average case response time to emergency, so how long does it take the National Ambulance Service, for instance, to respond to emergency call from the population? And if you look at the graph over the last 5 years, you could see that there has been improvement with respect to the average response time to emergencies. In fact, in the year under review, it reduced from 22 minutes to 20 minutes from 2021 to 2022. So we are being responsive, or gradually increasing, becoming responsive to emergency calls from the population. The regional breakdown shows that if you take Ashanti, Bono, and Greater Accra, the response time is very short or shorter than the other regions, and we want to believe the road networks and other factors may play a key role. Access to facilities may play a key role in reducing the response time in this particular case. But regions like the OT, as I mentioned earlier, because of other barriers, and Western region, it takes a very long time. For example, in the OT region, it takes close to 33 minutes for the service to respond to emergency call and pick the patient to the nearest health facility. The same applies to the Western region. The average case handling time, which talks about the time that the patient was picked to the facilities and handed over to the facility management to manage, and then the ambulance returned to the base as we refer to. The shortest time, as we got from the data, the analysis shows that it was in the Greater Accra region, and it takes about 1 hour, 45 minutes for the service to pick a patient and transport the patient to the facility, hand over, and return to base. We also recorded a very good time in the Upper West region. The highest time was recorded in the OT region. In fact, if you look at the OT region, in all the three indicators that talks about responsiveness to services were very high. The average vehicle engaged time is when the vehicle leaves the base, take a patient to the facility, and return to base. So with respect to that one, the highest time was recorded, once again, in the OT region, about 7 hours, 43 minutes. So it tells you there are a lot of barriers there for us to overcome to be able to transport patients who are in emergency conditions to the facilities. The lowest times were recorded in the Central region, which is, in the Greater Accra region. And as I mentioned, because of proximity to facilities and perhaps the very good road network may play a key role in having these reduced times. We also look at the bed density to population. How many beds are available to 1,000 population in this country? We all hear about the no bed syndrome, so we decided to also go into this analysis. And per 1,000 population, we saw that it's less than one. If you look at this, if you want to pick per 1,000 population, you have less than one bed per 1,000 population, or let's say one bed to close to about 5,000 population in this country. The worst were recorded in the Greater Accra region, the Northeast region, OT, Savannah, Upper East, and Upper West. So in these areas, we have fewer beds per 1,000 population in this country. And where we recorded a good performance according to the data is the Upper West region, which had, if you multiply by, let's say, 1,000, we have like one bed serving about 500 to 1,000 population in that particular region. So we have issues with bed to population density from this particular analysis. We also look at the available beds that we have in the country. What proportion or percentage is occupied in our various facilities? And if you look at the last 5 years, from 2018 to 2022, we had a dip in 2020. Close to 48% of the available beds were occupied. And then in the year under review, 2022, we have close to 60 of the available beds occupied in our various health facilities. So this indicator talks about the efficiency in managing the beds in our facilities, as well as the average length of stay. They all talk about how efficient are we in the management of the beds that we have in our wards. But if you look at the average length of stay, it takes close to 2 days in our emergency wards for a patient to be there, and then the patient will then be treated and discharged from the ward. So if you want to connect that one to the management of it in terms of efficiency, then we did improve on that compared to the year 2021, which we had on average around 3 days for a patient to be in the wards before he or she is discharged to go home. The family planning acceptor rate is also talking about the usage of contraceptives in the country. And if you look at the trend from the last 3 years, 2020 to 2022, it's been improving. The routine data tell us that close to 36% of the population are using any other form of contraceptives with respect to the family planning acceptor rate. I think the highest was recorded in 2019, which was close to 40%. But if you look at the last maternal health survey, the figure is around 1/3, which is 30% of the population using any form of contraceptive, either modern or traditional. But the year under assessment, as we can see, is 36% from the routine data. With regional disaggregation, we have so many people aged between 15 or above 15 using contraceptives in the Greater Accra region, and then the Savannah, Upper West, Volta region, and Western region. Where we recorded low usage in terms of percentage is rather in the Northeast region of 21, which is even below the national figure that we got, 36% of the population. The malaria incidence per 1,000 population, new infections of malaria per 1,000 population, has also been declining over the last 5 years from around 341 infections per 1,000 population to 178. So we are almost halving it, or we've halved it over the last 5 years. The regional disaggregation, however, shows variations. And Ahafo region, the Bono East and Central are recording very high incidence, malaria incidence per 1,000 population. Greater Accra is also recording the lowest, which is around 38 infections, number of infections per 1,000 population, which we need to discuss during the plenary session to understand why there's this huge variations between, if you like, the urban centers like the Greater Accra and then the less developed regions that we have in the country. We turn our attention to the prevalence of hypertension and diabetes. We all know NCDs are becoming huge or topical issues in this country. So we decided to also look at the condition in our country, and we saw that in 2022, this is the routine data, administrative data. The survey data may be higher than this, but based on the routine data, it's close to 2%, which is very low, of the population having hypertension or being hypertensive. And then if you look at the diabetes, those having the diabetes is also less than 1%. But as I mentioned, these are administrative data. If you go into the communities, the prevalence may be higher than this. And I'm sure when we listen to the Ghana Statistical Service in the afternoon, we may have some overview of the prevalence in the communities in the country. The people living with HIV, we have a global target to achieve 95 by 2025. In fact, it used to be 90 by 2023, where in 2023 we should achieve, for those having the disease or the virus, 90% should know that they have it, the status. And then 90% should also be put on treatment. And those put on treatment, 90% should have their viral load suppressed. We changed this indicator or the target to 95 globally, and we are to achieve it by the next 2 years, 2025. So if you look at the analysis here, you could see that in the year 2020, the blue chart or column is for those who knew their status. And that was a little over 70%. And then in 2021, it went down. But if you look at 2022, the assessment year, it went up to a little over 70%. Unfortunately, for those on treatment, that is the orange bar, in 2021, it was close to 90%. So those who knew their status and they were put on treatment, receiving ART and others, were around 90%. But in the assessment year, we recorded less than 90%, around 80, a little over 80%. And we understand that we need to do more testing to get those living with the virus or the condition to put them on treatment. The ones who have been put on treatment, and we expect that their viral loads will also go down. If you look at the year 2021, we recorded close to 90%. But in the year 2022, we recorded less than 90%. And one key reason for that, as we learned from the program managers, is that there has been a revision by the WHO on the lost to follow up guidelines. It used to be 90 days or 3 months, but it's now reduced to 30 days or 1 month. So it means that the lost to follow up, you may have so many people who may just beyond the 30 days. So within the 30 days numbers may be lower than as expected. So it doesn't necessarily mean that those put on treatment are not having their viral load suppressed. It's just the change of guidelines and then other factors concerning equipment and the reliability of the reagents that they use to do those things. The TB incidence per 1,000 population. In fact, there's a global estimate that Ghana is also pursuing that we need to go more to the communities and then screen for TB infection. So the incidence per 100,000 population, you could see that it went up to close to 53% from 43 in 2021. And then when you look at the case detection, so those who were detected to have it from the screening, it moved from 30% to about 38 or 37% in 2022. And if you look at the regional breakdown or disaggregation, we have the case detection rate very high in the Western North, and I believe because of the mining companies and other factors that may contribute to that, people having the condition over there. If you look at the Savannah, Northeast, and Northern region, the case detection rate for TB or tuberculosis is quite low. The treatment success rate is very high. It's about 87%. For all those detected and are on treatment, we are recording a success rate of around 87%. Even though we did not improve on the last years on, this coverage or this treatment rate is quite high and quite impressive. To be able to get to 87 is quite high. The blood collection index, the donation of blood to our various blood banks in the country or facilities per 1,000, the national target is that 10 donations per 1,000 population. But as you can see, for the year 2022, we are recording around 6 donations per 1,000. It means that we have a gap of about 4 to catch up to meet this national target that we've set for ourselves. But one interesting thing that comes from the data is that we are having more family donation as compared to voluntary donation. So it means that we need to do more sensitization to get people to voluntarily turn up to donate blood to the service. With respect to the regional disaggregation or decomposition, we are getting more people donating blood or more donations from the Bono East, which is around 8 per 1,000. And then Upper West, looking at the figure or the performance there, it means that we achieved the national target of the 10 per 1,000 because it's recorded close to 11 donations per 1,000 population. The West came from the Northeast and then the Bono East, where we recorded close to 3 donations per 1,000 population. So that is the picture with respect to the regional breakdown when it comes to the blood donations for our public health issues. We decided to also show this slide to let our development partners and other stakeholders know that in the previous health summit, the issues that went into the aid memoir, the implementation of all these issues, we needed to report to you how far we've gone with the progress of these issues. So last year's summit, about 15 key issues came up for the agencies, the ministry, and other stakeholders to implement. One of them was for us to complete the skills gap analysis in the data setup or the establishment of the health information system. And we are here to report that we've started this implementation. The World Bank is supporting us. They are procuring a consultant to lead this particular exercise. We were also asked to identify missed opportunities for children due for immunization it came up that we were not doing quite well when it comes to the urban centers with respect to immunizations of children. But I can tell you, or I'm here to report that together with the Ghana Health Service and other stakeholders, we are scaling up the mobile services to make sure we register the children in communities that may not come to the facilities for immunization. So that exercise, the scale up to urban centers, mobile clinics, is going or is ongoing. We were also to strengthen primary health care within the urban centers, which is also going. There are several interventions that the Ghana Health Service, teaching hospitals, and other stakeholders are also putting together to strengthen that. And then we were to also prioritize key activities within the health promotion. And there are a lot of health promotion activities ongoing on. If you look at the Health Promotion Division of Ghana Health Service, there are so many interventions that they are also implementing to promote health of the population in the country. So these are some of the things that we decided to show to you, that in the last year, the issues that the minister and the stakeholders, the DPs discussed, we went back and started implementing them. And we believe that the ones that we've not been able to complete, going forward, we will do that. So when we come back next year, we should have a complete picture for you to interrogate. So we encountered some challenges in doing this assessment. The first one is the fact that even though last year we reported that we were going to establish the national level health information system, the process is still ongoing. We have not been able to establish it fully. So we see it as a challenge, because if we're able to do that, we have all health data coming into the database for us to get a comprehensive data to do the assessment. The other challenge we also encountered was some of the indicators, we don't have a national representative data for them. If you take the hypertension, diabetes prevalence, and other maternal mortality, I'm even informed that in the 2022 demographic health survey, we did not capture the maternal mortality ratio. So what we have in the 2017 maternal health survey, which is around 310, is what we have based on the survey. So it means we need to do well to have the database and routinely capture some of this information for analysis. The other bit, which is also related to the fact that we've not been able to establish the national health database, is the delays in reporting. You reach out to agencies because we don't have the database to, collect the data. They have to go into their reports and other, manual ways to get the data for us. And all these things delay the assessment. But going forward, we believe that by the end of the year, we should have this system set up to facilitate assessment of the sector. So in conclusion, as we all see, with respect to the first objective, which talks about access to services, we had an overall score of below average, meaning that we did not do very well with respect to certain indicators. It doesn't mean that we didn't do well with respect to access to the services in general, but some of the indicators that we used to do the assessments, we did not do well. Some did not have even data for us to do that, and we needed to include that so that we push ourselves forward next year to get the data to do that. We did very well with respect to Objective 2, the maternal child health services and adolescent health services. We saw that mortalities, maternal and children, are all going down. Access to health professionals, for instance, the nurses and midwives, are also going up or improving. With respect to public emergencies and clinical emergencies, we also did very well. The overall score was fairly good. We did well with response to the case response time with the ambulance service. And the blood collection, we also improved on the last year's performance, even though we are yet to achieve the national target of 10 donations per 1,000 population. In doing this assessment, we had support and blessing of so many stakeholders, including the Honorable Minister for Health, the Deputy Ministers of Health, the Chief Director and Directors of the Ministry of Health, the agency heads, directors and unit heads of the Ministry of Health, our development partners, holistic assessment technical team, staff of MOH, and in fact, our sponsors who made this summit possible. Thank you very much for your attention.
I think he deserves better. A big round of applause for him. Yeah, so I'm standing in for the MC. But before we empanel members to do a thorough discussion, Dr. Linda Van Otu, if you are online, there are some questions or clarifications for the presenter. If you can pick it up, and let's hear you. Over.
Yes, thank you very much. And we say a big thank you to our presenter. We have a couple of questions, and so I'll now want to read some of them. We have one from a participant who says that I think NHIS for Central should be green, not red. That from 44% to 46% in 2021 and 22 respectively. So wants to know why we don't have it in green because of the difference. And then somebody is also asking, the data on health workforce, is it only for the public facilities or it's inclusive of private facilities? So that is another question. And then we have another one, says the doctor to patient ratio for Western was marked with asterisks, and they would like to know whether you have any reasons for that sign. So if we can kindly take these three, then we'll come back.
Very well, Doctor. We'll do just a bit of amendment. We'd like to have the panel discussion. Then after that, we can take all those questions and address that. I think the panel discussion may even address some of those questions in advance. So, ladies and gentlemen, at this point, I would like to invite the moderator for this particular session, Professor Alfred Yosin, Dean of the University of Ghana Medical School, to please come here on the high table. Let's welcome him. Let's also welcome the other panel members as well. The noble doctor himself, Dr. Eric Nsiabuatin, head of the Monitoring Evaluation MOH, to come here. Let's welcome as well Dr. Patrick Kumabuaji, DG Ghana Health Service. Please join us on the high table. Dr. Eric Nyedu, CEO CCTH, please join us as well. Thank you, Doc. Professor Richard Adanu, Rector JCPS, please join us as well. Then Dr. Divine Banyubala, Registrar MNDC, Doc, please join us as well. I'm told our General Overseer is still with us. I'm sure he's waiting for the last offering before the benediction. So, Prof. Moderator, I humbly hand over to you at this time to begin to stay affairs. Thank you.
Thank you. I'll stand here and start. Good afternoon, everyone. We are continuing on the existing protocols that were established in the morning. So we've heard the key highlights of why we are here, the holistic assessment. And the theme for this whole summit is sustainable financing for primary health care towards attainment of universal health coverage, the role of stakeholders. For us in Ghana, universal health coverage is improving access for all, limiting finance as a barrier to accessing health care, and making the health care financially sustainable so that we can provide timely and optimal health care for all. So it ties in very well with what we have. And then for us to do this, our key stakeholders, who we have empaneled here, I must say I have a good array of very reputable experts who cut across various stakeholders of the health system of Ghana. So we have the MOH, who happen to be the presenter as the head and policy-making agency of the ministry. That's where everything comes from. We have the key implementing agency of the government, Ghana Health Service, also representing all other implementing agencies, faith-based and all the others. Dr. Akuma Boaje is here. We have the training institutions. We've heard a lot about human and health workforce. Director of the Ghana College of Physicians, also representing all the training institutions, is also here. And everything we do, also, we need specialist care at the very highest level. So the teaching hospitals are also ably represented by the CEO of the Cape Coast Teaching Hospital. And last but not the least, whatever you do, you must be regulated so that you don't step out of line. The registrar of the Ghana Medical and Dental Council is also here. So you see, I have a very able panel to go through these discussions. So we will start. We have about 60 minutes for the discussions. We will see whether we can make it shorter than that so that we save some time. And then we will provide opportunities for us to interact and ask some specific questions. We will bring in our colleagues online as well. So we will start. I would rather like to jump the presenter and go to the next. So as I've indicated, we are major stakeholders in the healthcare system. CEO, Teaching Hospital. So we are all going to give briefly some highlight, what you picked from what was presented, what struck you the most. And we discussed that we'll have another round to tell us actionable point from where you stand going forward from here. So Doc, what were the key things for you?
Hello? Yeah, good afternoon. Good afternoon.
Probably.
Well, for me, it's been a very insightful presentation we have had this afternoon. It is intriguing to note that we are performing overall fairly good. I think we could have done better as a sector. But it is also notable here that we did not receive all our budgetary allocation. If you go into the details, you will see that we fell short of close to 3 billion cedis, if my record serves me right. So we may think that our investment, as expected, did not come, and for that matter, the overall assessment being that. But also worrying is the assessment for Objective 1, which was below average. And largely below average because we could not get the data that we require to do the assessment. I'm wondering whether we've taken steps to address that or we're going to come back next year having same challenges with data capture. It's also refreshing to note that the majority of our patients go to our district hospitals. I mean, that is why our universal health coverage is linked on primary health care. And it's been presented here that of all the best available, 5.14 patients, 5.14% go to the teaching hospitals. I think that on the surface, we need to go a little deeper to tell what teaching hospitals do, so that 5.14% doesn't look like we are contributing very little to service delivery in Ghana. In fact, the teaching hospitals are mandated to provide advanced tertiary healthcare services and then serve as training grounds for institutions that do training. So, rector does not train. The teaching hospitals largely train. But the colleges coordinate the activities. So it is important that we we speak to this 5.14 so that doesn't become like we are not contributing much to the health delivery activities in Ghana. I also think that our human resource doctor-patient population is not that good. I would have loved that we went a little deeper into the skill mix. We seem to focus on this indicator on numbers. So we are happy with the nurses, but we are not talking about the specialist nurses. It would have been insightful to say that even though we are meeting WHO's targets, we probably have a wide gap in terms of the mix, because we have the nursing colleges, we have the nursing training institutions, we are producing a lot more nurses. We even want to export some, but probably we need to also look at the mix so that we get things right. And the policy objective 2, I'm excited that the child health indicators have improved. But once again, I think we can do better, considering the fact that we have not enacted a deliberate policy in the country to look at the establishment of special care baby units across all institutions to start with. And then for the teaching hospitals, well-built, functional, operational, neonatal intensive care unit to be able to capture those who are not able to receive the attention at a lower level. I also captured that we are doing well in terms of maternal mortality ratio. That is very good, considering the fact that we have just 7 years to close on SDG 3. Nonetheless, in our performance reviews, we have seen that though some institutions are recording zero maternal deaths, others are recording very high maternal deaths. It means that if we focus our attention or interventions on where the mothers are dying, especially in the teaching hospitals, we may be able to, within a year or two, get close to the 70 target as is expected of us. I was expecting to have heard something on surgical site infection, which has been a major problem across our service delivery chain. Unfortunately, the presenter did not touch on that. So maybe in order that I don't, well, we also talked about bed density to population. If you look at the total beds we have in the country, and considering the fact that we're using only 50%, then there seems to be a problem. In fact, if you go to a teaching hospital, we are providing close to 4,500 out of the total beds we have in the country. But once again, we need to look at what teaching hospitals stand for and what are occupying the beds. Fortunately, we have anchored our universal health coverage roadmap to the primary health care. I want to say that is not to say that we forget about secondary and then tertiary healthcare services. So even though we are occupying 50% of the entire beds in the country, the 50% that is left provides room for re-engineering for maximum utilization, because everybody wants a new facility, but we are presented here that we have 50% of our beds, 59% of our beds occupied. It means that we have 40% of our beds that are still available. I think that one of the things that has not featured in the presentation has been the impact electronic health records has had on bed management and efficiency issues in the country. I would have loved that we had an indicator to measure such data. So okay. These are the few observations I made from the presentation.
Okay, thank you. That's from the teaching hospital perspective. We'll go to Ghana Health Service. Director General, please.
Yeah, thank you very much for the opportunity. I think well, below average, looking at or just fairly good, looking at our track record, that is not too good. So I think that's my first. But before I go into the details, I just want to also mention some of the broad areas, such as the data, among others. we have these systems and we always work to change them. I think this approach now is a bit rigid. What I can say is that if I have immunization coverage of 98% and I end up with 97 the following year, I may drop to -1 or something. I think it's a bit rigid. We need to look at it. Is that achievable? I use, for example, OPD per capita of 1.06. Is it bad? We are a youthful population, a relatively healthy population. What is our target for OPD per capita? These are to be factored in assessing the overall score of these areas. One other area that I think I want to also come up with is the denominator we are using. We have been using 4% for 0 to 11 months for the past 30 years. Our total fertility rate has dropped from 7 to about 3.1. Statistical survey gives us 0 to 11 of 2.7%. We are still using 4%. And so what happens is that as the denominator enlarges, your coverages continue to drop because it's getting bigger. And definitely the 0 to 11 is not 4%. And it's also not 2.7%. We need to find where really it is so that we can have some. Otherwise, next year, the maternal and child health indicators will continue to drop because the denominator gets bigger and bigger. 4% of 32 million is going to be bigger. 4% of 33 million is going to be bigger. And so I think those are the areas that we want to look at. But looking at broadly, I think what I can see is that the support systems are not working. If you look at the indicators, tracer medicines are down, HR issues are there, inequity issues are occurring. We have areas of insurance that is creating a problem. If you see the claims continue to drop, I think it's about time that there has to be a benchmark to say that whatever you receive, this minimum percentage must go into claims. But if you just leave it like that, we are not going to get payment. Tracer medicines are going to go down. Co-payment is going to go on. It's going to affect access to care. And of course, I never forget that my point about our infrastructure as part of the key development issues. We must also track how we are retooling. Have we retooled our equipment? When we started the hospital, when did we finish? Are we finished? I mean, these are all important areas of access that I think we need to start measuring. Otherwise, so my general point is that, yes, we expect what we are seeing because some of the key facilitating factors for allow our coverages to go up or quality of care to go up are down. HEFRA has a sizable number of unregistered facilities that affect quality of care. These are all things that I believe that we must also emphasize. So I don't really want to say too much about the details. I'm sure the questions will come. And that this is my broad overview of the report that is before us. Thank you very much.
Thank you very much. So Director General is indicating that the data and the indicators may be telling a story, but we need to look at it in the systemic view of things. If human resources continue to be a challenge, procurement issues, cost, reimbursement, budget allocation. So we need to, I also found it interesting, I must highlight, that the 60% of NHIS budgets were for claims. So I was asking what happened to the 40%. So maybe as we go through the discussion, somebody can explain to us what the other issues were for. And exactly what you mentioned. Again, the indicator on per capita OPD attendance. If your preventive systems are working and people are becoming healthier and not reporting to the health facility, is that in itself a bad indicator? So we need to look at how we interpret indicators such as this one. It may, for all you know, becoming better for districts and regions who are doing very well with preventive services, but it may not reflect per the indicator as it is. Rector, please.
Right, thanks. So my general comment about the presentation is that at least for me, when I listen to a presentation on assessments, I want to be able to, I obviously don't expect to remember every single thing that's been said, but I want to be able to go away saying that, are we doing well or are we not doing well? That's probably a simplistic view, but that's kind of like how I think about it. And in a sense, the report as presented makes it difficult to answer that question. Partly because the targets for different things were not mentioned. Because a helpful way would be to have what the target is and then what we achieve. Then you are kind of like taking it off in your mind that it looks like we're doing well. So, it's a good presentation, but it would be great to kind of like try to cater for those of us who think simply and just put that kind of thing there so that we can take how it goes. And are we having an impact on people out there? That's where things like morbidity, mortality, and life expectancy data might help. Having said that, the other thing is it would be helpful if the methods that we use are modified in the light of discussions that are held out here. Because what Dr. Boaji just said, he said the exact same thing last year. Nothing's changed in terms of the percentages and talking with Ghana Statistical Services. I'm also about to say something that I said again last year, and hope I won't say it again next year, or maybe that would cause you not to invite me next year. Is the whole thing about the skilled birth attendants. When I see it, I'm always like, what denominator has been used here? In the afternoon, we'll be hearing about the demographic and health survey data. I haven't seen that. I don't know the numbers. But I'm sure what we'll hear about skilled birth attendants there might be about 70 to 80% coverage. And then we are saying that for ourselves, it is about between 50 and 60. So what numbers are we using to get to that? So it would be good to kind of like hold this together with survey data and not just kind of like run an algorithm that sits there all the time. Because we are saying that we are covering only 60%. Then external people run a survey and say we are covering 80%. And they say it's not true, we're actually doing worse than you are saying. And we shouldn't kind of like be going that way. Another general thing is that if you look at the graphs from, I think it started from, I can't remember, maybe from 2015 or something, down to 2022, the gradients are generally flattening out. They're generally flattening out. The early part, it kind of like went down, and things are flattening out, which, going by those graphs alone, one wonders whether we are doing well. Or maybe the question to ask is, are the inputs coming in at the right time? Is it that what needs to come in from government isn't coming? As we become low middle income, there are certain things from the donors that wouldn't be coming. Is it that government is not putting in what it should be put it in, so that we can make those kind of statements? This is an assessment of us. We should be able to say that. But it's frightening to know that the graphs are flattening. And that in a sense seems to suggest that we're not doing too well. There was some explanation about the people living with HIV and the HIV data, which when I saw it first, I was like about to have a convulsion. Then an explanation was given, and I realized that the explanation wasn't a good enough anticonvulsant. Because I'm worried about that it looks like we're kind of like dropping the ball on people living with HIV. So I'll stop there. Those are my immediate reactions to this. Thank you.
Thank you, Rector, for highlighting that. So it's important, I believe, that we will, going forward, as he indicated, some of the things that have been mentioned previously in previous summits, we take it into consideration and try to see, for example, I will highlight again the nurse population ratio. We are always saying our nurse population ratio is above that of WHO and all that. But how many critical care nurses are there? how many emergency care nurses. If we lump everything together, we might feel we are doing well, but it might not help us in planning to support the system very well. So those are things we believe that we may need to modify the system a bit to reflect how it can educate and inform us going forward.
Thank you very much.
Registrar, yes.
Thank you very much, Prof. I think that my general comments are that this was a fantastic presentation, and we want to thank the ministry, especially the directorate responsible. And Eric, you did a fantastic job. So the conversations here are just what we could do better, so that we can move. Excellence is always an aspiration. And I'm just following up on our moderator's lead. When I was listening to, from a regulatory perspective, you hear doctor-patient population ratio, nurse population ratio, and it may look good. The first thing is that the focus reference was to doctors, for example, on government payroll. Now, that immediately presents a problem as to the sufficiency of the broader consideration and whether or not we are not undervaluing our output. And therefore, if we examined it like that, then the second level is we need to have a much more nuanced and reflective approach. What is the regional distribution of these numbers? And are we just satisfied with the gross numbers, or we are interested also in the skills mix, so that we are able to disaggregate these data, not just according to region and facility type, whether they are teaching hospitals or the regional hospitals, whether they are CHAG or quasi-governmental or private, but also what are the specialists we have? Because we cannot have a focused approach to driving quality, safe, basic healthcare services for every Ghanaian everywhere in this country without having a focus on the type of personnel and at what level. And it worries from a regulatory perspective greatly when there are still issues of maldistribution. Let me put it this way: inequalities in the distribution of numbers. Then these inequalities over the years have not been sufficiently addressed. Then they transition to inequities. Now, once you begin to talk about inequities, then you are close to the next level, which is inequities less unaddressed, become iniquities. And once we are in the area of iniquities, that is because of my failed Catholic priest background, it becomes issues of justice and fairness. And from the regulatory perspective, I noticed that in the earlier submissions, there was reference to incentives-based approach to achieving equity in distribution of personnel. But there are also regulatory tools available to us to be able to support. So it's not only incentive-based. While we say that is great, and I'll give a practical example. From the perspective of the Medical and Dental Council, we had a very big problem where between Greater Accra and Ashanti region, we had 80% of all our doctors. And I'll give you a practical example. House officers, first and second years, nearly 85% of them were all in these two regions. Then the board took a policy decision to ensure that first, to be able to train house officers, you need a specialist at the membership level. Then we started to engage our counterparts, Ghana Health Service CHAG, and they started to slowly get members to the districts. Then the policy followed. If you do 1 year in this region, you must do a second year outside that region, save under exceptional circumstances. Now, Greater Accra accounted for 55% of all house officers at the time. 4 years down the line, we are down to 38%. So there are things that when we act collectively, cooperatively, and we coordinate our actions at various levels, so that when we are having presentations in the holistic assessment, we should be having regulatory components coming through, we should be having service delivery. Nonetheless, majority of it will be service delivery related. But we want to also see more from the training component, quality assurance mechanisms to ensure that these healthcare services are actually not just quality, but they are safe, and they are being provided by the appropriate cadre at the right levels. And when you begin to unpack this package, then we have clearly defined boundaries. This will give our people clarity. It clears confusion as to what the professional they are seeing, what is the scope, and that will impact on what will be paid for, at what cost, at what level. So these are my general initial conversations, and I once again to thank PPME and the ministry generally, and Eric for giving us a fantastic presentation to be able to unpack. Thank you very much.
Thank you, Registrar. Yes, so Registrar is indicating the need to include other indicators on regulation and other components of service delivery. Eric, I'll come to you if there are any key issues for you, even though you did the presentation. Is there anything you want to, again, highlight for us?
Okay, thank you very much. I think I welcome all the feedback, and we will go back as a team to work on it. I think our main goal is to continue to improve on what we do. So having experts here to give us this feedback, we appreciate it. We will go back, and next year, these issues will be addressed in the report. What I want to also say is that there are other issues that, for the sake of time, we decided to put them in the report, which will be shared. So the presentation focused on, we're so much interested in the indicators that we report to the global databases. But when we share the report, you will see some of other national level indicators. But I think one key thing I want to look at when we go is the disaggregation into the different specialties for doctors, nurses, and all those things. So that even if you are doing very well, we need to see with respect to these specialties. Something that we will do. The challenge has always been the data but we will still contact the agencies and get and to do those things. Thank you very much.
Great. I think, again, as you mentioned, the data and the issues that may arise, Prof. Adanu mentioned it. Do we realistically believe that skilled delivery is about the lowest in Greater Accra region? On the face of it and what we see around, that many mothers are delivering outside health facilities in Greater Accra region. So there are things we will need to question as we go forward. And it's by so doing that we will improve the system, as Dr. Insia Boateng has said. So I'll come back to my facilitators for them to give us their considered expert opinion as to how to improve general access, how to improve maternal, child health, adolescent care, and also provide a responsive system that will deal with clinical and public health emergencies. But I also want to give opportunity for more questions. As the questions come and we deal with it, then we can, at the end of the day, summarize it. I wanted you to have this at the back of your mind so that we will give us something actionable that we can work with going forward. So if MC is here, I want to open for discussions. We will take those who are here physically, and then we will take our online colleagues. We will be equitable and fair to everybody. Yes. So that we don't fall into the trap of converting it to iniquity, as the registrar said. Yes, please. We will take WR and then So for now, please. So 1,
Hello.
2, 3, 4, 5. For now, then we go to the back. So 1, 2, 3, 4, 5.
Let him speak. No.
Yeah.
Thank you very much. I just want to highlight 2 points. First of all, this study very well describes the descriptive aspect, but it does not clearly elaborate on the why and the reason behind the good numbers that we have seen. And this year is really a data-rich year. We have demographic and health survey, harmonized sales facility survey. We have the holistic assessment and the STEP surveys coming out and the expenditure reviews that we are going to see. So my plea would be, would it not be a very good time to do a kind of review of the health sector to see why these numbers are there and what is the link across these numbers? I mean, we may not, this is not something, the kind of reviews that we will do every year, but we can do it as a kind of midterm review of the health sector plan and see the reason behind the numbers. And if there are any issues with the numbers, we will identify issues of denominator, issues of, with the assessment. That is one. Going into the specific numbers, I just want to raise one question among others. If we go to 2 regions, Greater Accra and Eastern region, in terms of human resource density, particularly in terms of medical doctors, they are the better off. Possibly they are the better off in a number of inputs. But when you looked at skill delivery, I think that both of them are among the lowest. In terms of maternal mortality, both of them are among the highest. In terms of neonatal mortality, Greater Accra is the highest. Is there no discrepancy here? And what is the possible reason? The subject matter experts might tell us more. Thank you very much.
Thank you. My panel members are taking note, as well as Dr. Nsiamboating. So we will take all the questions. WR, please.
Thank you very much. And just to build, first of all, to say, Eric and the team, for this work that you're doing. You're really keeping us on our toes to really get some understanding on what is happening in terms of health in general in Ghana. And I think we should encourage you to even do better. Just a brief comment around the public health services versus the private sector services. I note from your outpatient data that almost 30% are either private, attendance to outpatient are private or quasi-government services. Are we capturing that aspect of data? Because then it will point to a number of things. For example, in a more affluent district or town like Accra, the chances that most of the deliveries or some of the significant deliveries are being done in the private sector, becomes important. And so when you tell us 40% in Accra, should we be reading much into that compared to the fact that probably a lot of the good private sector services are actually in Accra? The second point I was going to mention, and since you kept referring to WHO, was that WHO sets minimum standards. And I think as a country, we should really be looking at this information against our peers. So if we say we are doing very well with 1.9 per 1,000 in terms of nurses and we pat ourselves on our back, what are our peers doing in terms of similar investments in training, similar investments in the human resource and the different portfolios? I think we may find ourselves that we may be doing worse or better. But that's why I think this analysis should be looked at, not only to pat ourselves on the back, but also to say, when we look at our comparators or people that are in a similar situation, we are doing better. We are investing more in health. We are getting better outcomes in that. So just to point out that maybe going forward, we should have an analytical input into this. Then lastly, just a suggestion for next year, since everybody is looking ahead. The presentation
and I'm being honest and probably speaking on behalf of my chair, should really start with a review of where we are coming from. Because it sets a base to argue that you are making progress. For example, we had 15 things that came up in our aide memoire. And I saw that we just rushed through and everything was ongoing. How much of that ongoing has contributed to the excellent performance that you are telling us? So maybe going forward, and I'm offering on behalf of colleagues, I'm sure they will agree with me, that when we prepare for the next health summit, that we probably have a small group of colleagues from the different agencies, from the Ministry of Health, to interrogate the data that we're seeing, but also reflect on where we are coming from, so that we learn. If we did something very good from the aide memoire that has contributed to that, we highlight it as a good practice that we need to invest more resources into. Thank you very much.
Thank you. Yes, so 1, 2, 3, and then we.
Thank you very much. Reverend Dr. Tipo, contribution. Holistic assessment is based on figures or data. The country has no denominator, and we cannot say much until we correct that. The world has moved from clinical medicine to social medicine with Amata Convention, WHO, 1976. But the presentation is based on clinical medicine. We have to base our assessment on the 100 core health indicator by WHO. Refer to the WHO website. Thank you.
Thank you.
Thank you very much, Chair. So, excellent presentation. If I use the indicators that you use yourself to assess the work that has been done. I was a bit concerned about the scores and then the poor, below average, and then the excellent. Because when you were describing the use of the tool, fairly good and good, I observed that you said for good, there was stagnation. And for fairly good, there was an increase compared to the baseline. Maybe you need to look at that again. Did you interpose the criteria that you were using? Because I don't see how stagnation can be better than some marginal increase compared to the baseline. And then number 2, when you describe the universal access primary health system, which was the first objective, you indicated that overall there was some missing data, and I think one of the speakers has alluded to this. So if you had conducted a household survey and actually found some data, would this have improved the rating that you got? Because lack of data and then a final analysis that this is poor, I think is not correct. If you couldn't find the data and then you conclude that the assessment is poor, then it means that there is a problem with the assessment, not that there has been no improvement in the particular indicator that you are measuring. I mean, if you can't find the data, you can't say that the service is not good, whereas the service could actually be okay, but it is your method that is unable to obtain the data. So you need to look again at how you interpret the indicators, because then the final conclusion is what we see. I think you finally said fairly good, but no, you said something average, below average or average. But according to your own criteria, average and below average are not satisfactory scores. So please be careful when you use as Prof said, the assessment criteria and then what you finally concluded. I think the missing data is very relevant. We need to have the missing data. Thank you very much.
There was one.
Yeah, mine is on neonatal deaths. You mentioned Ashanti region and Greater Accra. I would want to know if these are based on the facilities within those regions, or they are deaths actually experienced by the citizens of those regions. Because I might have cases where people are transferred to, say, Ashanti region, and then they die. Are you considering them as people like Ashantis who died? Or, yeah. So we need to, at least, the data must show where they are coming from. So if we are not capturing their location, we have to capture, so that when you do such analysis, you drill down. Okay? Then, on that same one, we have a chart, big chart. Which ones are you highlighting? I saw red, but I would suggest that next time, you highlight those ones, the two key ones that you addressed, Ashanti region, Greater Accra, give them separate sheets. Talk about them first before you bring the general one. And my last one is on where you have, say, three service providers. And then you come up and say, one had this, one had this, one had this. Then you do the regional breakdowns. It will be proper if at the regional breakdown level, you also bring in the providers. Okay? So that we know, oh, maybe these people are concentrated in these areas, these regions, where we know from the data that those regions, they are not even attending the facilities. So it doesn't look like, oh, they are not doing well. They might be doing well, but maybe they are located in certain areas where the people are not even patronizing the service. Right, thank you.
Thank you. We'll take last one, Stephen, then we will get responses from the panel.
All right. Thank you very much. So mine is maybe whether it's contribution or a question. But maybe, Eric, I just find myself, let's say, 3 years ago, also presenting on behalf of the ministry. And I hope that most of the questions and the contributions we are making will not be centered on you, but on the entire health system. So I'm looking at the part, especially with the outpatient services. And I know that the Ghana health system itself is pluralistic, also focusing on orthodox and traditional and alternative medicine. And to that effect, I know that there are regulated traditional alternative medicine facilities in the country, also providing services. In fact, some of them have the integration with both the orthodox, and on the other hand, a number of our orthodox providing facilities, especially the public institutions, also have the traditional alternative medicine there. Now, when you look at the OPD per capita, I'm tempted to also believe that if a person attended the alternative or the traditional facility, and that information is not captured in the system, then we might not be able to achieve whatever target that we set. Hitherto, I would say that if a person attends the health facility once in a year within a healthy population, then that is a very good maybe health system that we are having. But if we looking at the pluralistic nature of the health system as far as the ministry is concerned, if we're able to capture, or if we capture that aspect of it, then that may also explain a bit as far as the per capita is concerned. The second one is also related to the linkage between the ANC1, ANC4, and then also skill delivery, which may seem to be going down. I know that many years ago, people living in the urban areas would go and deliver in the rural setting. So, for example, we are living in Accra, and then my wife gets to close to term, she will go and deliver at her parents' place who were living in a certain rural area. So in that sense, we may see OPD, the ANC attendance may be very good in the urban setting, and then they may go and deliver in another, maybe in a rural facility, because that is where the parents were. So I think that we may have to look at that aspect of it as well, as far as the service delivery is concerned. On the other hand, could it also be that people attend the ANC here, but they also go and deliver outside? Because I know that a lot of people want to deliver outside, especially in the US and all that. So that, if we look into it, may also help us to know that gap between attending the ANC and then also not delivering. Then the third one, I know people are also being attended to at home. they get a skilled person to come home. And I think I have maybe quite a sizable number of people who attend the ANC all right, but when it's time for them to deliver, they deliver at home, and then the provider comes home to deliver them. So maybe for service delivery, if we go deep into some of these things, that may account for that aspect of it, vis-a-vis what the statistical service may capture as part of the health and demographic survey. Thank you.
Thank you. So what we're going to do is the panel members will respond to this, and then we'll give opportunity for our colleagues online to also ask a first round of questions. Then we'll come back to our in-person audience. So, panel members. Eric.
Okay.
You are the man of the moment, so.
I will leave the, I will leave the, if I may put it, the non-data issues to the expert, and then I will try and look at the assessment issues that came up. I think one came from WR, which we have taken into consideration that we will be comparing ourselves to the sub-region and see how far we are also faring with respect to some of these indicators. Prof. Ambofo mentioned the scenarios that we use. I think the stagnated and increased, that was with respect to the baseline. So if you look at the target for those two issues, if the target is met and then you stagnated, we gave a score of 1, which is good. So you met your target, but compared to baseline, you stagnated. The other one is that you missed the target, but compared to baseline, you increase on it. And that is the 0, which is fairly good. So that is how, maybe in the presentation, I missed it out. But I think one point that has also come up, which the technical committee would decide, with respect to the indicators that we didn't have data for. We could have thrown them away and have green and yellow. That would show that we did very well. But upon second thought, we also said that it's our duty to also get the data. What are we doing to get the data? So that is why we factored them in. So I agree with you. If you take them out of that, obviously the scores will be higher. But we needed to also make sure that we are not throwing the ones we don't have data for, but we need to put in effort to get it. But all this will be discussed at the technical committee level, and the decision will be made. If you have to throw the ones we don't have the data for, and only concentrate on the ones that we got data for, we will do that and change the scoring. Thank you.
Yes, I agree with you on that, but it's important not to throw data away. Otherwise, then you create another indicator that will show whether data are complete or incomplete, something to capture so that we don't lose the important data. Prof, please.
Yeah, picking on what Eric just said, I think we shouldn't be doing the analysis kind of like taking out those without the data. But then maybe it's more of like after we've reported all this, we could then do another analysis alongside it. And then compare the two. But the overall report should be like you've done it, because our inability to produce the data is an assessment in itself of how the system is doing. And the comments about the ANC and the skill delivery, I don't think the practice of like people coming for ANC, going outside, or coming for ANC and going to deliver maybe in their hometowns explains this fully. And that links to the point being raised about let's interrogate this further to get the reason behind the numbers. Because if we look at the demographic and health survey data over the years, our ANC coverage has basically been at like 90%. So that's where, like what Dr. Boaji said, if it was 98% last year and it's 97% this year, why mark us down? I mean, it's still excellent, although it's dropped. So that has always been there. But the skill delivery percentage has always been lower than the ANC. And the concern has been that maybe some of these women who really value their pregnancies and would go long distances to go for antenatal care, when it comes to the time for delivery, maybe somebody else is taking the decision. So that's where we have that gap, including a few who are probably going out. And when people are delivered at home by skilled birth attendants, it is counted as a skilled delivery. It's counted as skilled delivery when the surveys are done. When the surveys are done, it's counted as a skilled delivery. So it doesn't reduce it, because the women are asked who conducted your delivery. And once it was a midwife or a doctor or whatever, nobody asked where it was done. So then that counts as a skilled delivery, although maybe where it was done should be looked at, but not, it's looked at for unsafe abortions, but not for deliveries. So I think I'll stop.
Thank you. I'll come to Dr. Abuaji, but I wanted to, Eric, please. WR asked, the data you presented, does it include the private sector? Because that's a major point too. If the women are delivering in private health facilities in Accra, are they captured in this one?
Yes, there are some private facilities that report to the DIMS too. Okay. So the first data I showed about the utilization with the private facilities, the data from those private facilities are also factored into the analysis. But we admit that not all private facilities, as we speak now, report to DIMS too. Yeah. Thank you.
DJ, please. Then I'll come to.
Just to continue from where Eric ended, we still have new private facilities springing up, especially Kumasi and Accra, and not all of them are reporting, and so you tend to have some challenge with the data, and that's why you see Greater Accra reporting 51%. But you go in this afternoon, you see what the DHS will report about the highest. They always come out with the highest coverage because of that lack of reporting. You're going to see about 90% of skilled delivery in Greater Accra compared to that. But my general comment is that I think the report must be, the data, the regional distribution must be interpreted within the context. If you look at neonatal deaths, Ashanti region covers, Komfo covers about 5 regions. And so you're going to have a lot of referrals into Komfo, and that will go into their data. Kolebu also plays the same role. It's even better now. Ridge is taking some of them away from them. 37 is taken. And so you're going to see that once you see a higher neonatal mortality in Accra, doesn't mean that there's something wrong, because they are receiving from all over the country. So it has to be interpreted the same way. If you look at OPD per capita of 1.97 in Western North, most of them are Ivorians who are seeking care, and they are not part of the denominator. You get my point? And so I think it has to be interpreted within that context to make sure that we really are interpreting the results. Most of our border towns have skewed data that has to be interpreted appropriately.
As DG said, I believe it's in line with what the chairman said this morning, that we don't have to take our eyes off the hospitals, the district hospitals. Because if the district hospitals are working efficiently, then they may be able to deal with some of the problems that will come to Kolebu, that will come to Reg, that will come to Komfo. So at the end of the day, in totality for the nation, we are going to save more lives of women and neonates as well. It doesn't matter which region or where the teaching hospitals are. CEO.
Yes, I think that we are exhibiting here that we have some challenges with data capture and data validation. If you look at the methodology that was used to arrive at this assessment, one would have thought that since it came from the bottom to the top, they would have captured all the information from the bottom to the top. So maybe there's a dissociation between the data used for the summit and then the key performance indicators that the service providers and other agencies are supposed to churn out. And I think that we should look at that. If you look at the presentation, you see that people living with HIV who know their status are less than those who are on antiretrovirals. That is not possible. And if we don't get the data right, then all this we are sitting here doing will not be relevant and will not be able to come out with any meaningful contributions. I think that if you look at the OPD per capita we have provided, I know many institutions now are doing home care services. So it will be interesting to have also stated that it's an access avenue that we have, and I'm wondering whether that is even captured as part of the data. And I also know that many institutions are leveraging on the digitization of the government's agenda of digitization and are providing telemedicine consultations. And these are also pieces of data that we need to be able to capture so that we can get the right things here.
So we will go to Eric. Any response, or we can go to the online. Yes, please. We will go to our online audience for their questions. If our IT personnel will help us.
Prof, can you hear me?
Yes, please.
Okay, so thank you very much. Just as the in-person participants are active, we are also very active online, and we have a number of comments and questions. So someone is saying that he or she thinks the NHIS to the central region should be green and not red. So I think that Mr. Eric, please take a look at that and kindly check so that we can rectify it if that is what should be. And then another person is asking whether the data on health workforce is only for the public facilities or inclusive of private facilities. And I think that some answers have been given to that. There's also a comment about the doctor to patient ratio for the Western region, which was marked with asterisks. And they would like to know what that means. So why do they have that? Then the OPD figures that were presented, someone is asking whether they include the drugstores and herbal clinics. If so, what are their respective contributions? If not, why are they not captured? Then we have something about blood donation. And the question is it just family versus voluntary or mandatory versus voluntary? So this is a question about blood transfusion. How are we getting blood in the country? I don't know whether you have answers to that. There's also the issue about, in the past several years, CSOs have always participated in the panel discussion of the holistic assessment. They would like to know why this time round they have been omitted. I'll go on to the next one. It says one key parameter missing in the holistic assessment is accident and emergencies. Because RTAs are on the rise due to increased use of motorized vehicles, and the holistic assessment needs to include injuries and disabilities. Then there's also the issue about the fact that since this particular summit is sponsored by MOH and other partners, can there be a 6-month CSO health sector summit that interrogates the data and reports presented? I think that this probably ties into some of the comments that we have heard. Another one is that the gap between survey data and routine data is from the incomplete nature of routine data. So data from private and sometimes from faith-based health institutions are often not submitted. This is also something that has been discussed, and I believe that the ministry and agencies and others would be looking at this. Someone is wondering why facilities should account for patients registered on NHIS when it is not GHS registering them. And that person thinks that it is good to know, but to score facilities on that point needs to be looked at. So again, about the modalities for scoring facilities. Another one is that there is need for monitoring maternal deaths by community to throw more light on deaths in regions that do not have facilities to manage severe complications that may result in death. And this will enable focusing strategies to address the community factors. I think that this also ties in with what we heard, that people come to the Kofanochi or Ashanti region to deliver and die. In the meantime, they are coming from elsewhere. So there's that need to look at where the deaths are occurring and then address the issues from there. I'll probably share last one and then we can take some answers. Somebody says that he or she shares the modification agenda and thinks that if we can modify the system in regards to the staff skill mix at the lowest level, we will perform better next time. And the person has gone on to give some suggestions, which I hope will be captured, and we can look at them. The person says that our specialists, nurses, and doctors should be posted to the lower levels to impact the younger, inexperienced ones. 2, if we are able to do this, it will have a positive impact on our case fatality rates. 3, we will not have more complicated cases in our regional and teaching hospitals because most of the complicated cases that end up in the bigger facilities are mostly preventable. The next suggestion is that it is very sad how the mortalities we record in our facilities occur. We should not be happy because we are doing fairly well based on the indicators. Let's humbly come down to the lower level facilities, identify the real challenges, and take proactive steps to deal with the challenges. We still have a lot to do in terms of staff skill mix in order to make maximum impact in achieving UHC by 2030. I will end it here for now, and probably we take some responses, and we have a couple more which we can add on. Unless, Prof. Moderator, you want me to complete the others.
I think we will take responses for these ones, and then we'll come back to you. Prof. Adamu, yes.
I think some of the comments are like treating the presentation as though it's a scorecard. But I don't think, Eric, are you presenting a scorecard?
No.
Okay, I don't think it was a scorecard, but you have to have a way to disaggregate the data, and it looks like the method we are using is by the region where it occurred. And it's not kind of like saying one region is worse than the other, but that's based on the data as it came. So we shouldn't kind of like be tied to it as if they say the thing happened in Kaswa, that means that I'm a doctor who's living in Kaswa and I'm not doing anything about the health thing. It's not that. There has to be some. An actual of looking at it is that if the indicators in a region are bad, then the director PPM is here. I mean, she controls the budget. She will direct more money to you. So maybe you should wish that your indicators are lower, then you get more money. So let's not think that it's a way of stigmatizing any region. I don't think that's what Eric meant to do.
Thank you, Prof. I think that's a very good one. DJ, please.
Well, I think probably just to add to what Prof said, if they came and they didn't die and they paid IGF, you take it. You see, so, and we have a catchment area, and you don't decide who your catchment area is. Kaswa is central region, but nobody's going to Cape Coast because it's in central region. And so you need to manage them based on the situation you are in, and that you should, if you are in Kolebu, expect cases from central region, eastern region, etc. And I think that is where that facility or the region must work towards improving care, including even putting follow-up visits to see if they feel there's something happening there that you're not happy with, you can go and support. But we will not be able to address it if you think that central region go to central region and Greater Accra will just take Greater Accra. It's not going to happen. People decide where they go to, and the catchment areas are fixed, and that's why the teachers also make a lot of money because of the case that comes to them.
Question on CSOs.
Yes.
Oh, that CSOs are not part of the panel. So I'll speak for the organizers. It's noted, and next year they won't make that mistake again.
Thank you.
Anytime DJ wants a quarrel, he picks on the teaching hospitals. I think it's important that we establish that teaching hospitals do not have boundaries, geographic boundaries. A service that is available in Tamale can be accessed by somebody from the Western region. So, as we take the money, we should also take the responsibility. What we should talk about is that we should be well equipped and always ready to perform the task up to our mandate. Nobody will leave Nigeria to Cape Coast because we treat malaria. They will leave Nigeria to Cape Coast because we are performing that advanced surgery, that laparoscopic surgery, that endoscopic surgery, that robotic surgery. And that has the potential to reaping the resources that we are crying we don't have. So I'm talking about medical tourism. So teaching hospitals, our figures will not look too good, but we make a lot of money from the bad figures. So I want to entreat that we build our systems to be able to absorb the responsibility that is on us. Last time, Dr. Dia said somebody left Central Region to Chak in Accra, facility in Accra, because the services in Cape Coast Teaching Hospital was not good. And I say this because he's smiling at what I'm saying. So teaching hospitals do not have geographic boundaries, and I think we should take it like that and then accept the data as they present to us badly.
And then accidents and emergencies and injuries.
Yes, I think that's from road traffic accident is one of the SDG indicators that we are also looking at. So we've reached out to the Motor Transport and Traffic Department to get the data. They are in charge of getting data from road traffic accidents. So if the report is finalized, which we will consider the discussion from this plenary, we will consider that particular indicator in the main report. There was an issue on blood voluntary, where we talk of voluntary and then family donation. I think the service referred to the family donation as mandatory. So the family donations are also called mandatory donations. We couldn't get data from the drugstores and the pharmacies, but we've had discussions with the Pharmacy Council and the College of Pharmacy to see to what extent that we can also get data from those facilities in the assessment. The Asteris, some of the indicators before 2021 and 2022, we were using the 10 regions. But the 2021-2022, we managed to have data for the additional regions that were created. So we put Asteris there to show that, for example, if you take Ahafo and you have Asteris, that data may include Bono East. And so we've provided footnotes in the report to explain those things. Then the NHIS coverage, the central region figure, if you look at the national coverage, it's around 55%. So those below the 55%, we decided to give them red. And then those above, scoring 70, 80, were green. And like Prof said, this is not a scorecard. I mean, there are explanations to why the central region is around 45, 46. And if you look at over the years, that has been the coverage in the central region. So that is it. Thank you.
In the interest of time, it's been an interesting discussion, but we need to be mindful of time as well. I think one thing we've not highlighted, WHO mentioned about the need to have a forum where we discuss all these different data sources. The DHS is giving a figure, maternal and child survey, mixed thing. So if there is the possibility to have a forum to discuss all this, bring it on board. I think it will be helpful. That was asked from the beginning. So we take it. So would you agree with me that in the interest of time, we allow our panel members to give their expert-considered opinions as to all the discussions we have, what they will want to see next year's health summits to be like? Do I have your, if it's in the university, you say approve. All right, so we will start with just a minute each, if that is okay.
All right.
Yeah.
Thank you very much. So my minute, from a regulatory perspective, we should pay particular attention to focusing on training the appropriate cadre, following clear assessment as to optimum numbers for the various specialty and subspecialty levels cadres, so that we aim to train towards that. And to make sure that we leverage on all resources, public, private, quasi-governmental, diasporan, to be able to do that. In terms of improving upon our data quality issues, whilst vertical accountability is a very important tool, and it is important for us to emphasize on our separatedness as agencies, we probably will have to have a second look at paying particular attention to horizontal interconnectedness of sector actors. And that brings me to the elephant in the room. Is it time for us to relook at the structural issue? Maybe these operational challenges are coming as a result of a foundational problem with the structure. Relook at 525 and restructure to have a much more unified system that does not diminish separateness, but enhances horizontal interconnectedness. I submit.
Very much. Prof. Adanu, please.
All right, thank you. So I think one thing that the ministry probably should do going forward from the discussions that we've had is to continue to work to basically serve as a Ministry of Health and not a Ministry of Public Health Facilities. So leaning more on the private sector so that we get that data in. I don't think we'll solve it all by next year. But then if that's an ongoing thing, if that's an ongoing thing, we can make sure that maybe in a few years to come, when we present the assessment here, to be actually an assessment of the health service delivered within the country. And the other thing, which is linked to what the question you asked about the looking at the data, I think we don't necessarily have to, well, eventually we'll need to disseminate that to everybody. But it would be good if the ministry convened a group, a small group that would take these different data sources and ask the questions as to how do we bring them all together and come out with, let's say, a presentation that brings all this together and represents what's happening in the country. Right, thank you.
Thank you very much. DG, please.
Prof, I hope you give me 2 minutes.
Approved.
Thank you. I think from what I said earlier, we have some of the background facilitators that we tend to ignore. Human resource, availability of medicines, laboratories. These are areas that we really need to, but these figures don't change on their own. It's these things that make them come up, and then if the quality is improved, then you also get the right outcomes. And I think we should not just focus on the service outcomes, but also some of these things that are very important, like I mentioned. And so, looking at that, even for HR, we are saying we've done so much for net population ratio. Let's agree, we have 60% of our nurses as auxiliary nurses. Is that what we are using? Is that what we should be using? I think we need to take a decision on that to see how we are addressing some of these issues. We must fast-track the issue of the denominator. We had a meeting with Statistical Service once in Kumasi early this year. I think we need to come up with some figure. Other countries have done it to be able to distort all these things. And I believe that there's a need to improve coordination. I just want to take up from what Prof left about public, but I think even as the agencies together with the ministry, we must work more closely together, including even generating such a report. And also, there are regions with very peculiar problems. We should not treat them all as if they are the same. If you go to OT, they have the least number of facilities there, and that's why they don't have insurance. People don't even have their cards. How do we look at it? If you go to Northeast, if you send 3 nurses there, there'll be nowhere to sleep. How do we address some of these challenges if we want to improve these areas? And finally, I think we must, as Ghana, we must compare appropriately. When I go to international reviews, I go to Bangladesh, I go to Nepal, I go to Sri Lanka, I go to see what they are doing. Because if we start comparing ourselves within our sub-region, we'll go to sleep, and then we'll be caught. And I think we need to really move forward if we take the bar higher than where we are. Thank you very much.
CEO, please.
Prof, 1.5 minutes. Prof, I think that going forward, we should find innovative ways to capture our data and then validate them appropriately so we can make the best of decisions. I think that we are doing so much for universal health coverage by leveraging on primary health care. But I think it is time that we make a business case for the tertiary health facilities to receive the necessary attention that is required. I think I want to see a ministry that is coordinating us to have access to the donor partners, to understand that, yes, mothers are dying, and they are dying because we don't have ventilators. The mothers are dying because we don't have critical care equipment. So we want to see the ministry make a very, very critical business case for the teaching hospitals as we support the roadmap to universal health coverage. I also want to see in the holistic assessment proxy indicators for advanced tertiary healthcare services so that we can boost our medical tourism agenda and then provide that mandate that teaching hospitals or tertiary healthcare facilities are supposed to have. If I'm a teaching hospital and I'm providing services like a regional hospital, now what makes me a teaching hospital? Is the establishment of medical school. So we should have proxy indicators to measure advanced tertiary healthcare services in the country. I want us to agree that we should have a satisfaction survey to know from our clients whether we are delivering on our mandate or not. And one most important thing that we need to discuss is rational use of medicines. You know, antimicrobial resistance is a global health threat, and we've not had the opportunity to talk about rational use of medicine in this forum, and not even talk a lot about, antimicrobial resistance. Recent studies are showing that in 4 metropolises in Ghana, we are seeing improper and unapproved prescriptions in all our pharmacy outlets. I'm talking about Kumasi, I'm talking about Greater Accra, I'm talking about Tamale, and then the other metropolis. So these are some of the few things that I want to see done next year.
And Eric, please.
Okay, thank you. I'll talk about 2 issues. The first one will be the data gap. Next year, we need to try as much as possible to close the data gap. And we will also try by making sure that we get the health information system established. That will help us close the data gap and also engage other partners. The second bit has to do with the aid memoir implementation. As a ministry, I think we need to organize, I'll be frequent with the Health Sector Workers Group meeting and then the interagency leadership meeting. That is where we can ask our leaders of the agencies to provide update on the progress of implementation of the aid memoir. So we would engage them during those meetings, so that next year when we are making presentation of the aid memoir, we'll be able to speak to the specific, exactly what they've done with respect to those issues. Thank you.
So we thank you very much for our in-person participants. You may clap for yourselves. And then for our online participants as well. So before we round up, finally, we will give opportunity for the chairman to make some remarks on everything we've said. So I will try to do something 2 minutes, highlighting the key things we are taking forward, and then we will invite chairman to give us a closing remark for the session. So what we have discussed and learned, key amongst them is that the ministry should be a ministry for both private and the public sector, and that there should be the horizontal coordination. And then we don't need to compare ourselves with our peers only in the sub-region, but elsewhere in the world as well. Data issues continue to come up, and we should take all the measures that next year when we come, you will see an improvement of what we have presented, as well as the systemic challenges that beset the system, that these indicators should be explained within the context of the systemic challenges as DG highlighted, HR denominator issues. And then the ministry has agreed to convene the small group to interrogate all the different data sets and also the aid memoir with stakeholders, so that next year we will expect a presentation on the aid memoir, the progress we've made, where we are and where we want to go. So thank you very much, but we will reserve the last applause for the chairman, if she is. Please, sir.
Thank you very much. One of the advantages of being the last to speak, you can always say, all that I want to say has been said. And in fact, all I wanted to say has been said. Just 2 points. We've been doing this holistic assessment for many, many years. So it's important that it evolves over time. This summit started as a Ministry of Health summit. So it was okay for the holistic assessment to be focusing on Ministry of Health. Then it evolved into the Health Sector Summit. And therefore, it moved from just looking at Ministry of Health data into data from the private sector and others. And we are struggling with that. Now we have moved into a Health Summit. So some of the data will not even be within the health sector. So we need to bear this in mind as we move along. And I think we're doing quite well. We need to look at one of the importance of this assessment is to help us look at, are we achieving our goals? Are we achieving our targets? But we looked at is just service delivery. But we have other functions. Are we doing our regulatory work? Are we doing our policy work well? And since this is an assessment, it should not be just an assessment of service providers. It should include assessment of CSOs. CSOs are not supposed to just criticize. Assessments of the development partners. It's not just looking at assessment of the players from this end. So I'm hoping that in future we'll look at that. My little worry is as we move along, we should also be simplifying. And I was a little worried that we've moved from the simple 3 colors to rainbow colors. And sometimes it's becoming confusing, rainbow colors. But as Patrick also mentioned, part of the time should also be asking questions, why? Why? Why are we not performing? Why are we performing? And a lot of it depends on the support system. So it will be useful to look at that. But I think it's also important that we bring different people together before we present the assessment to do some analysis before we present, so that the discussion is not only about the data, but also what it tells you, because the assessment is very, very important. Otherwise, the indicator may mean different things. There is a story, and this is my last point, of a trotro mate who, because you know about these traffic indicators, green means go, red means stop. So he was asked when he went for his driving license, what does green mean? It means go. What does red mean? Stop. What does amber mean? It means go very fast. So this is what is learned from Ghana. In Ghana, amber means goes very fast. So the interpretation of even indicators are very important. So thank you very much.
Let's do it better for them. I think we've been sitting for almost 3 hours, and we need to go very fast to eat so that we can come back very fast as well. That is what Amber means this time. Thank you so much. The choir is with us, and they are going to bless us with another administration whilst we all get ready for lunch as well. So the very same place we had coffee, we are going to that same place for lunch, and our guests will be ushered in to have their lunch as well. We have only 35 minutes. 35 minutes, we are back here. Thank you. Please carry your laptops along. Go with your laptops. Either you keep it in the bag or you go with your laptops and tablets. Please do that. Yeah.
From get to you. Oh, what's that? No, you're going to send a boat to the okay. My presentation is no. From there, we need them right now. I'm back telling.
Mr. Beats. It's Gears on the beats. Mr. Beats. Mr. Beats.
Abedipo. Charlie. Too conscious.
Mr. Autry on the sax.
Move. Showers. Move. Donzi.
loving you. Je t'aime. Mi fait. I love you. Je t'aime. Mi fait. I love you.
may sa tëndi jor yaa moom lile may sa tëndi jor yaa moom lile may sa tëndi jor yaa moom lile ni woy birma fu mu yendu ma yendu fa yendoo naane woy birma fu mu yendu ma yendu fa yendoo naane ni sambalole, ya mom lile. Buri sambalole, ya mom lile. Buri sambalole, ya mom lile. Ne woy birima, fumayen fayendo nane. Woy birima, fumayen fayendo nane. Tamel me sa tendi joro, ho ho ho. Sama waji kendu jam nane. Woy birima, fayendo nane. Kirimone man, besamba. Kuli meja singilap, biram gamu. Gune meja nyas, bay meja jeri. Samba ya sino, dike bay kujadoki. Yai borom baba, ini woy birima. Yow sama waji kendula jam nane. Woy birima, fayendo nane. Dogo falek mawajor, kuma sampai ay jalor. Dogo dogo, azizo may dogo, hamdu yon way. If it's love that you're running from, there is no hiding place. Just your problems, no one else's problems. You just have to face. So if you just put your hand in mine, we gonna leave all the troubles behind. Gonna walk, don't look back. Don't look back. 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 If it's love that you're running from, there is no hide your days. Just your problems, no one else's problems. You just have to face. So if you just put your hand in mine, we gonna leave all the troubles behind. Gonna walk, don't look back. Don't look back. Gonna walk, don't look back. Don't look back. Gonna walk and don't look back. Don't look back. Gonna walk, don't look back. Don't look back. someone else will come. So if you just put your hand in mine, we gonna leave all the troubles behind. Gonna walk, don't look back. Don't look back. Gonna walk and don't look back. Don't look back. Gonna walk and don't look back. Don't look back. Gonna walk, don't look back. Don't look back. We gonna walk, don't look back. Looking in
right. The meeting has been called to order. I'm sure others are still eating. All those outside, please come inside. Let's start the final session. All those outside, respectfully, please come inside. Let's start the final session. Let's encourage those who are outside to please come inside. And let's have the final session, please. Let's encourage them. Thank you for coming. Thank you for coming. Those who are still outside, thank you for coming. Thank you. Thank you. All right. Can we go? Since the chairman is seated, with his permission, I'm sure we can proceed. Presentation. The worst subject anybody wanted to do those days in school after lunch was mathematics. But I'm very sure Prof has a way of capturing the attention of students. Ladies and gentlemen, at this point, we have still made some amendment quickly, and we are going to look at the highlight from the 2022 Ghana Demographic and Health Survey. This will be done by no other but Professor Samuel Kobna Enim, government statistician. Let's welcome with a round of applause to do this for us.
Thank you very much. Good afternoon, ladies and gentlemen. I didn't get a response. Good afternoon, ladies and gentlemen. I'm trusting that lunch is not having a toll on us already. So, colleagues, thank you for enduring up to this session, which is the most difficult part of the presentation. But in the next 25 minutes or so, I'm going to walk you through the highlights of the key indicators report from the 2022 Demographic and Health Survey. I was speaking to my colleague and I said this coincidence of the readiness of the key indicators report and the health summit is really awesome because it gives us an opportunity to look at where we are as a country and ask ourselves the basic question of whether we have to review some of our indicators or not. So what I'm going to do this afternoon is to give a very brief background. I'm very cognizant of the background of people that I'm speaking to, do a very quick methodology, and because I want to focus on the findings, I'm going to dedicate about 20 minutes of the presentation to the findings. And I'll put this into 4 categories. We'll talk about the fertility and reproductive health, child health, nutrition, and end off with HIV testing and sexual behavior. From my point of view, I thought that given that this is a health summit, it will be important to put this presentation in the context of the health sector medium-term development plan and look at the targets that there are in there, and based on what we are seeing from the 2022 DHS, as I indicated earlier, ask ourselves whether it's about time we revisit the targets that we have in the health sector medium-term development plan. Indeed, this is something that falls within the broader goal of GSS to start profiling all policy documents in this country and ask the simple question on whether there are statistical targets in our policy documents, whether the targets in there are accurate and whether the targets in there are realistic. I would end off with some key takeaways which would guide us. So, Demographic and Health Survey has been with us for 4 decades now, and the basic question that it seeks to ask is, how can we compile, analyze data on issues around population health and nutrition statistics? As I said, I'm going to narrow down very much on the health sector medium-term development plan. I was not part of the drafting of the plan, but definitely reading the plan, there are some numbers in there that I think we can juxtapose it with what we are seeing from the 2022 DHS and ask ourselves whether we are on track or not. GDHS is global. It was structured, or it has been structured in a way that is going to capture at least 1/5 of the 231 Sustainable Development Goals. I was happy to be part of the previous session before lunch that talked about the fact that we need to go away from looking inward and looking outward. So DHS has been conducted in over 90 countries, so it always provides us the opportunity to do international comparison. And since it's been done since 1988, and Ghana is doing the 7th round, although globally we are doing the 8th round, there is enough room for us to check how we've progressed or retrogressed over time. For the first time, Ghana Statistical Service will go into district-level analysis, doing some small area estimation. All of you are aware that the sampling of the DHS, it's nationally representative and it's regionally representative. But now with methodological advancement, we'll be in a position to provide some estimates of all that we are talking about at the district level. And given that, we're looking forward to get the main report done in the next couple of months or so. Once that is done, these analytical reports at the district level will start. So this is briefly by way of background. Again, I wouldn't bore you so much with the methodology. It focuses on women as a primary target, and from that we get the children and we get the husbands. So that is the target that DHS focus on. So it's mainly looking at the health and nutritional status of women and children, but given that it collects data on husbands living with these women, we are able to do some analysis among women as well. So the instrument for the data collection is put into 4 categories. We have the household data that will give us the context, and then we have the women's questionnaire, we have the men's questionnaire, and with the different testing that we do, we have the biomarkers as well that allows us to do the different tests, including anemia and malaria tests. So we ensure that it's not nationally representative by going back to the 2021 population housing census, of which we identified 618 enumeration areas or otherwise clusters where they form the national representation and the regional representation, from which we target households, 30 of them each in these clusters. We identify women in their reproductive age bracket between 15 and 49, and for men, we target those between 15 and 59. Data collection spanned the period 17th October to 14 January 2023. So it's pretty much on our minds the scope of issues that we've covered and how readily they represent what is happening on the ground. So as I indicated, I'm going to start with fertility and reproductive health issues. And as the MC indicated, my aim is not to just put numbers out there, but put numbers out there with a clear sense of what is happening at the disaggregated level and what is happening over time. We are arguing strongly that anytime we focus on the headline figures, we use statistics to communicate whether we are performing well or not. And we want to change that narrative. If we really want statistics to work for us as a country, then we need to look at it from an input point of view. And that is why we're going to focus on the trends and the disaggregations. So the first headline figure is total fertility rate, which is 3.9 for 2022 Demographic and Health Survey. I'll be quick in saying that during the 2021 population housing census, we got a figure of 3.1, but we always see the DHS data as more reliable than the census data, simply because census is the entire country. There are instances where we do proxy reporting. So anytime we get fertility rate from census data, we do adjustment historically and with current data to enable us to do the population projections. So as of 2022, based on the Demographic Health Survey, the official statistics on total fertility rate is 3.9. But the key message here is what has happened over the period. So we started collecting data in 1988, and since then an attempt has been made to do it every 5-year period. In 1988, when we did the TFR, it was at 6.4. And now we're talking about TFR at 3.9. If you look at the trend carefully, what is happening is that there has been a drop in 2.5 beds over this 4-decade period, but two beds out of the 2.5 happened between 1988 and 1993. So we saw that significant drop there. And what that is telling us is that of the 2.5, 20% is accounted for only in the last 3 decades. Later on, I'm going to show you a slide based on the health sector medium-term development plan in terms of how this target has been set. But let's keep in mind that if you've experienced a drop over 4 decades of 2.5, and 20% and 80% happened in the first 10 years, the other 20% is accounted for over a 3-decade period. Any projection that you are making should keep in mind the extent to which you're going to see a drop, given that in the last 30 years, it's dropped by only 0.5 beds since the third round of the DHS. Then from a rural-urban perspective, we are seeing rural beds per woman 4.8 and urban 3.2. Again, what we are seeing here is the difference is about 1.5 times between rural areas and urban areas. So anytime you want to think about a national target, a regional target, a residence target, you need to think about what is going to happen given that it's dominated in the rural areas than urban areas. Then the second statistic that I share with you is teenage pregnancy. So here again, if you go into the health sector development plan, you see a target of 12.0. While we put emphasis on the disaggregation is that nationally we are seeing 15.2% as a 2022 demographic and health survey. So at the national front, we are seeing that we are off the target by about 3.2 percentage point. What is more concerning is the extent to which you are off the target at the regional level. At the regional level, you identified 6 regions that are really off the national average, which is 15.2%. This tells you that even though at the national level we are off the target, at the regional level we continue to see some regions that are deeper down off the target. And this is the kind of reflections that we need to have if we really want to achieve our national target. The difference between the region with the highest teenage pregnancy and the lowest is from 25.9 to 6.0. Then we look at the drivers. This is the area that most of the time we leave it to the academics to do, but we're now hoping that within the policy space, we can look at the drivers of this. So teenage pregnancy, from the report that we've seen, is mainly driven by education and wealth status of households. And you see very significant differences between children with teenagers with no education, having a rate of about 24.3%, and those with secondary or more having 12.5% as those being pregnant. And you see a difference of about twice those with no education relative to those with at least secondary education. The story is not different when you look at the wealth status. And again, teenagers in the lowest quintile of wealth have a rate of about 23.1% relative to about 5.7%, indicating about a 3-time difference between teenagers that find themselves in the lowest quintile from a wealth perspective and those that find themselves in the highest wealth quintile. I'm not going to go through this throughout the presentation, but it's dominant across all the indicators that we're going to share with you this afternoon. Then we touch on 4+ antenatal care visits, which is the recommended. We look at this over time, and we also look at this across the 16 administrative regions, keeping in mind the national target of 60.0. So we have a national target of 60.0, and we see that from the 2022 DHS, we see a figure of 87.6. As a statistician, the first question that I ask myself is, where is this 60.0 coming from when in 2014 GDHS we had a rate of about 87.3? So from the 2014 GDHS perspective, the 60% target had been reached. Let me recognize the fact that if you go through the health sector development plan, if you go through their target, an attempt is made from where each data is sourced from. So possibly this can be coming from other data sources like the maternal health survey or the multiple indicator cluster survey. But this is the time that we need to ask ourselves, how comparable are these? From a statistical point of view, they are comparable because they are nationally representative and regionally representative. But once you see a target that had been met from the 2014 Ghana Demographic and Health Survey, then you ask yourself the question, how was the target set? Having said that, we see stark regional variations from the 4+ antenatal care perspective. We see these variations with having regions, including the Savannah region, including the OT region, and the northern region, recording rates that are pretty lower than what we see at the national level of 87.6%. So between 2014 and 2022, we made only a marginal progress of 0.3 percentage points. This marginal progress, as I indicated, is way above the national level. But at the regional level, that is not the story. We see stark variations across the 16 administrative regions. And when you see the southern part of the country, These are the regions in the southern part of the country are the regions that are recording rate 87.6 and above. But then if you go up the country, northern part of the country, as I indicated earlier on, specifically the Savannah region down to the OT region, we see rates of about 79% and 75.7%. Intermittent preventive treatment during pregnancy, recommendation 3+ doses SP/Fansidar. And also from this perspective, we see a national target of 64.1. Progress being made, especially between the last demographic and health survey, that is 2014, and now. But then again, you see stark regional variations, especially what is happening within the northeast region part, the northeastern part of the country, and towards the OT region part of the country. One region that stands out in this, which from my point of view should be looked at, is what is happening in the Ashanti region, where we see a rate of about 49.9% for intermittent preventive treatment. Percent of births delivered by skilled provider. This conversation came up in the previous presentation. Again, we've set a national target of 60.0, consistent with what we saw earlier on. The 2014 statistic from the Ghana Demographic and Health Survey indicates that as of 2014, that target had been met. So we need to go back to the drawing board to ask the basis for setting that target, given that the target was reached about 8 years ago. Consistent with the previous findings, we see stark regional variations, again dominating the northern part of the country, specifically the three northern regions, or the northern region that has been divided into three, namely the current northern region, the Savannah region, and the OT region, and as well the northeast region. Contraceptive use for married women 15 to 49 years from 1988 to 2022. So we have this trend data, and what is promising about this is when some method is used, whether a modern method or a traditional method. And clearly what we see here is that the uptake of contraceptive use has shot up by 9.6 percentage points between the last demographic health survey and now, moving from around 26.7% to 36.3% over this 8-year period. Having said that, it's important to step back and look at what is happening at the regional level. At the regional level, we keep in mind the national rate. The national rate was 27.8%, those who are using some modern form of contraceptive. So from the national level, we've achieved that. But again, we identify regions that we are yet to see reach of the target for modern contraceptive use. Specifically, we find regions like the northeast region, the northern region, the Savannah region, and Bunu East region that are recording rates lower than the 25.0%. What is striking for us is the case of Central region from the use of traditional methods. The Central region is recording a case of about 16.3% for the use of traditional methods. This is about 12 times the region that is recording the least, which is the Bunu East region, of 1.4% of traditional method of contraceptive. This stark regional variation really draws our attention to how are we using our regional operatives to address our health challenges. We turn the conversation to child health, starting with childhood vaccinations over the same time period. Here, what I want us to focus on is what is happening since 2008. Since 2008, we see that fully vaccinated children, that is the basic antigens, we started dipping from 79.0 in 2008, 77.3 in 2014, and now 75.6. That alone is not concerning when you don't think about the fact that the proportion of children that do not have any vaccination also over the same time period is showing an upward trend. So over the same time period from 2008, we had 1.0 of children who had no vaccination, and this number keeps creeping up since then. 2014 Demographic and Health Survey, we recorded 1.6, and currently 2022 GDHS, we're recording 2.0. We could look at the national target of 95.0 and say that we are reaching that national target of 95.0. But what about these people that we are likely to exclude? Keeping in mind that we don't want to leave anybody behind. So the focus of this slide has to do with the 2.0 of children that have not received any form of vaccination. Similar to the previous slides, we see stark regional variations. Based on the national schedule for fully vaccinated children 12 to 23 years, we get a national average of 56.4%. From this national average, we identify 5 regions that are above it. What that means is that, 6 regions that are above it. What that means is that we have 10 administrative regions that are below the national average, with the least being the northern average. So it always presents the masking of statistics at the national level. And this is why I gave the preamble that we now need to focus the conversation on the statistics being used as an input based on the disaggregates rather than the aggregates. When I was going through the health sector medium-term development plan, the question that I asked myself, and I'm putting it to all of us, is when we are writing our policy documents, why do we say that the data will be disaggregated at the regional level, but we don't provide targets at the regional and the district level? Going forward, I'm hoping that that is going to dominate the conversation for us to think about having statistical targets at the regional level and not just reporting the outcomes at the regional level, because the interventions are going to be different. The story is not different with children with no vaccination. This is pretty much striking. You talk about the national target of 2.0. You identify 5 regions that are recording less than 0.1%. But then you have 2 regions that are outliers, that is the northern region and the Ahafo region. The northern region having as high as 9.0 of children that have not received any form of vaccination, closely followed by Ahafo region 8.3. So between the national average of 2.0 and the northern region, we've seen a variation of about 4.5%. And this is the stark variation that repeatedly you're going to hear me say throughout this presentation. Malaria prevalence, this was captured from 2 perspectives, either using the rapid RDT approach or the microscopy approach. Fantastic progress being made. We've seen consistent decline since the 2014 GDHS. Comparing it with the Ghana Malaria Indicator Survey, we see a drop, and currently we're talking about 8.6%. Nationally, this is where we are, but we find regions like the OT region recording just close to twice of what is happening at the national level, about 15.0% of prevalence of malaria in the OT region. Then on the other side of the coin, you see the Upper West region recording 13.4%. National picture 8%, masking stark variations of what is happening in the OT and the northern region, with rates close to about 1.5% what we have at the national level. From the perspectives of exclusive breastfeeding, as a country, we peaked during the 2008 Ghana Demographic and Health Survey. An upward increase, indeed a very steep upward increase from the first Ghana Demographic and Health Survey, from 2.2% to about 67% during the 2008 Ghana Demographic Health Survey. For some reason, there was a significant drop to about 52.2% in the 2014 GDHS, and we are yet to recover, given that we made just a marginal progress of about 0.5% between the last GDHS and the current GDHS, which is reporting about half of children who are going through exclusive breastfeeding, specifically 53.1% of children. Early childhood mortality, under 5 mortality before 5, infant mortality before 1, and neonatal mortality before the first month. And what we see here is progress being made from all 3 perspectives. So from all 3 perspectives, we see a downward trend. What we really need to think about is, although we are seeing a downward trend across all 3 early childhood indicators, the rate of variations vary across these. And I'm going to draw your attention to this when we come to target setting. To keep your mind, to look forward to that, one of the things that I'm going to highlight, anytime you see a policy document that thinks about rate of change in a constant way over time, it tells you that as an institution, over time, you are not too sure what you're going to do in the next 1 year, which is going to be different from what you're going to do in the next 2 years and what you're going to do in the next 3 years. So for that reason, if you have a development plan, you set targets and say that over the years, it's going to reduce in a constant way by 2%, 5%, and 6% in each year, which definitely is not something that it's achievable. So we are seeing a downward trend across all that, but then we need to think about how this is responding to our targets. We turn the conversation to nutritional status. Again, we had a national target of 16.0 for children who are stunted, height for age. We see significant progress from our first Ghana Demographic and Health Survey, with a figure of 32 or so percent, right down to about 17.5%. The first takeaway is that from a stunting point of view, we are off our target of 16.0, which means that there's a variation of 1.5 percentage point difference between what we said we're going to achieve as a country and what we had achieved as at 2022. Emphasis is on the disaggregations across the 16 administrative regions. And across the 16 administrative regions, you see the Northeast region and the Northern region recording rates close to about 30%, which is about twice what we are seeing at the national level of 17.5%. I did emphasize the contributing role of education and wealth status, and the story is similar to what we saw with teenage pregnancy. For stunted children, we find them more predominant among households, those with no education, and also among households in the lowest quintile. Another anthropometric measure that we are all interested in is children that are wasting, wait for height perspective. This is one of the statistics that between 2014 and 2022, we are seeing a retrogression. In 2014, we had a rate of 4.2%, and in 2022 Demographic Health Survey, we are seeing 6.0. So the prevalence has gone up, 4.7 to 6.0. So the prevalence of children that are wasting, that is wait for height, has gone up by 1.3 percentage points over the 8-year period, that is 2014 to 2022. The national target of 6.8 has been achieved. Again, this takes us back to on what basis did we set the national target of 6.8 when in 2014 we had a prevalence of 4.7. Maybe it was a misreading of what the health sector development plan is, but definitely this calls for some conversation around what goes into the setting of targets and how statistics from different surveys and also administrative survey can help us better understand the targets that we want to achieve. If you look at what is happening in the eastern corridor of the country, right from the Volta region through the OT region and up to the northeast region, we see we are recording rates that are higher than our national target. Again, we are seeing Ashanti region recording a rate that is higher than the national target of 6.8 and also the national average of 6.0. Underweight tells a similar story like wasting. We've seen a retrogression also by 1.3 percentage points. In 2014, we had a rate of 11.0. 2022 GDHS, we are recording 12.3. Obviously, this calls for concern on wide retrogression, even when we are not meeting our national target. This is one of the indicators that I struggle to find a benchmark figure for it from the health sector development plan and also future targets for it. For some reason, it was marked somewhere, I didn't say it, but definitely it calls for us to discuss it when we are seeing a retrogression in children who are underweight in the country. The story is not different from what we see in the northern part of the country with rates about 20.4 and 19.9 for the northeast region and the northern region, compared to the national average of 12.3%. Anemia among children 6 to 59 months. This is your area, given the different classifications of children who are less than the 11 grams based on their blood levels and those who are not anemic based on those who are greater than 11. We see significant progress being made from the last but one demographic and health survey, 2008, 78.3%, dropped significantly to 68.7%, and now 49.0%. But what is striking for us is the drop from a severe anemic perspective, those who are less than 7%, where we see a significant drop from 5.8% from the 2003 Ghana Demographic Health Survey, recording a percentage point drop of about 5.0 percentage points to 0.8 from the 2022 Ghana Demographic and Health Survey. So again, from the national target point of view, which is 60.0, based on what we recorded in 2022 Ghana Demographic Health Survey, we are off the national target by about 11.0 percentage points. Regional variations, very glaring. So keeping in mind the national target of 60.0%, we identify regions like the Hafo region, Greater Accra region, Eastern region, Bono region, that are recording rates lower than the national average. And this clearly calls for us to think about what is happening. If you look at the various categorization of children with anemia, the variations among those who are mildly anemic has hardly changes across the administrative regions and over time. The changes is really occurring among those who are either moderately anemic or severely anemic. And definitely this requires concern in terms of what is causing the changes across different geographical areas and also over time. The last thing I want to talk about is HIV testing and sexual behavior. This definitely should strike all of us in terms of population 15 to 49 years old that have never tested for HIV. There is a concern here because here it includes not only those who have not tested, but those who refuse to test it. So I'm not going to put emphasis on the 73 as against the 42%. But what I want to put emphasis on is the gap between females and males and the fact that the gap keeps widening. So if you look at our 2003 Ghana Demographic Health Survey up until the 2022 Ghana Demographic Health Survey, we see a widening of the gap between males and females in terms of testing or ever tested for HIV. And we see these significant variations again at the regional level, with regions like Central and Ashanti region recording the highest variations between men and women who had never tested for HIV. Then the last slide from the key indicators report has to do with mean number of sexual partners in lifetime for population 15 to 49 years. Again, we find very significant variations between males and females, males having 7.0 lifetime sexual partners, with females having 2.6 lifetime sexual partners. Again, what is striking here from my point of view is how it peaks across different age cohorts. It peaks with the age cohort 30 to 39 years, but right from 15 to 19 years and upwards, you see that it's a function of the different age cohorts. So given these perspectives, as I indicated, I thought for purposes of your conversation during this summit, and for each table we've placed this document, and I'm hoping that that is what is going to start the conversation. We didn't have enough copies, so for each table we have 3 of them there. Soft copies are available on our website. But this is the conversation that, from our point of view as a service, we should start engaging in terms of profiling our policy documents, engaging in policy audit of what we have. So we have the baseline as it was in the health sector medium-term development plan, 15 indicators that we're able to identify in the health sector medium-term development plan and from the DHS. And of the 15 indicators, we identified about 8 of them that we say that we are not in a position to determine whether we are making progress or not, simply because we saw variations between what was in the health sector development medium-term development plan and what we have in DHS, or the figure that we have in the health sector medium-term development plan would quote a source which has a figure different from what we had in the 2014 Ghana Demographic and Health Survey. One of such statistics has to do with prevalence of anemia in pregnant women, where in the health sector medium-term development plan, we see a figure of 50.8%, which is not consistent with what we see in the 2014 GDHS, which quotes a figure of 44.6. So based on that, although we're seeing some progress being made, we are saying that it's good to exercise caution. We need to be circumspect in drawing a conclusion that indeed we are making progress or not. So of the 15 indicators that we're able to pick up from the health sector medium development plan, we had about 6 of them that points to the fact that it's either we've met our target or we are making progress. I say this with a lot of caution because there are 2 of them that one has to be careful, and I said that in my presentation. In the case of stunting, we realized that we've made progress from 18.8 in the 2014 GDHS to 17.5 in the 2022 GDHS. But with our national target of 16.0, from a stunting point of view, we've not met our target. From a wasting point of view, we did indicate that we had retrogressed by 1.3 percentage point. So although we had met the national target of 6.8, given that in 2022 we saw 6.0, indeed we retrogressed as a country from 4.7 to 6.0 between the 8-year period 2014 GDHS and 2022 GDHS. I made a submission earlier on that if you look at the targets, and specifically if you look at a target like modern contraceptive preventive use, 2022 target of 12.0 reduces by 2 percentage points, 2023 target of 10.0, reduces by the same margin, 8.0, 2024 target, and 2025 target reduces by another 2.0. What this simply tells us that you have the same pot of money, you have the same pot of people, you have the same circumstances over the next 4 years, so there's not going to be any variations in your target. This definitely should call for concern, because at any point in time, you have your different interventions, you have your different sources of money. So given the different interventions and the different sources of money and the different skills at the disposal of the ministry and the service, definitely it should inform variations that would occur over the period. We identified 3 indicators that had retrogressed over the period, and as I indicated, we're not able to make a determination
Recording
on
stopped.
8 out of that. This suggests that my time is up. I end with key takeaways. Very brief. We've made progress with some of our targets: anemia in children, infant mortality, and under 5 mortality. We have retrogressed in some areas: teenage pregnancy, underweight, and wasting. Clearly, I've emphasized the fact that it is time we revisit our baseline and the determination of future rates. It is important to recognize the fact that there are a lot of instances where the national targets have been met, but the regional targets for some of our administrative regions are yet to meet the national targets, and the issue of stark variations across regions cannot be underscored. I'll conclude by thanking all those who supported us for the 2022 Ghana Demographic and Health Survey, and look forward to the main report and the release of the microdata. Thank you.
And take the questions. After this detailed work, is that all we can do for him? Wow. I'm sure, Mr. Chairman, please join us here. Please join us, because this is also very, very important. We had wanted to make the 2 presentations, but I think we need to take questions on this particular presentation. I'm sure the chairman will help us maybe do that for us. But if you have any question on it, the ushers are with the microphones. Dr. Linda, you are online. If there are also questions online, let's know that as well. But quickly, yes, we have one here. We have 2. Am I permitted to do that for you? Okay, thank you, Chair. The microphones, please. Ushers, help us. Okay, so one from Dr. Eric. Then another speaker. All right. So, Dr. Eric, just a minute. Yeah. Okay. Yes, please.
Okay. Thank you very much, Prof, for that presentation. You made reference to the health sector medium-term plan, specifically the baselines and targets. In fact, that is true. Some of them, at the point of developing the document, we did not have the survey data to help us determine the target for the next 4 years. So if you look at it, most of them you rely on the administrative data from many teams too to set the target. So now that we have the results from the Demographic and Health Survey out, we will very soon go into the media assessment of the medium-term plan, and we have the opportunity to revise some of these targets that we set for ourselves. Thank you.
Very well. The next one.
Thank you very much. Prof, you spoke like very fast, like a politician who want to finish quickly to get to Parliament. that was good, because I was even feeling sleepy, but your speech actually woke me up. Now, my issue is that I work in the NGO sector, and I noticed that you mentioned OT more than 15 times. which brings my mind to the fact that when the 6 regions was added to the 10, has Ministry of Health taken the opportunity to group those 6 to disseminate this kind of data to just those 6 for them to understand where they are standing and where they will be in the next 20 or 10 or 20 years' time? I think if MOH hasn't done that, you should organize a program for the 6 new regions. Because we go to workshops, we hear this, Savannah, we hear that, we hear that. But we know that we were born in the 10 regions. You see? So please, that is my put it in your plan. Organize a small workshop for them and give them all this data so that they can understand their problems and improve upon it. Thank you.
Thank you. Very well. Interesting. Any other? All right, we have one here. Online partners, kindly alert us if we have questions online as well.
Thank you very much. Just one point, something I was raising starting from the beginning of the DHS. I mean, what is the plan to do maternal mortality rate measurement? Maybe it can be answered by either the Ministry of Health or the Ghana Statistical Services. Thank you very much.
I didn't hear that myself. Anyway, I'm not the one to answer. So. Any other? Okay.
My point is maternal mortality rate is not included here. Okay. It was not included in the census. How are we going to measure it in the near future? Maybe Ministry of Health or Ghana Statistical Services can reflect on this. Thank you.
Very well, very well. Any other? Dr. Linda, do we have any online, any question online?
Mine is just something that maybe you should consider adding to the teenage pregnancy. You only considered education and wealth, right? But I also think as part of our social identity, religion counts a lot. So maybe you should look at religion as well. It should be.
Are we clear on that? Okay.
Okay.
All right.
So
Let's talk.
Okay, so one of the comments is that the 2014 GDHS included the measurement of blood pressure. Was this variable included in the 2022? If no, why was it excluded? Looking at our challenges with NCDs. Another says it's an excellent presentation. And then someone is asking whether you can provide the link to the website. And very educative. And so those are the questions we have in the comments now. Over.
Very well. After lunch, questions are few. So, Chairman. Prof, you need to address this.
Thank you very much. So the first one, disseminating the results to the 6 new regions, is definitely that GSS will do regional dissemination. So we're going to go into all these regions. The other side that we've not considered is bringing them together. So this is something that we can take it up with the ministry, and more importantly, take it up with the Ministry of Local Government, Decentralization and Rural Development. This is a conversation that we're always having with the minister. The fact that they are new and their experiences would have to be brought to the fore. In terms of maternal mortality, this is something that in the main report, we're going to have it. In the census, can you correct that? Yes, in the census, we had the maternal mortality. We had it in the maternal survey as well. In the 2022, we didn't have it because at the consultation stage, I thought there was a point that one of the institutions said was going to take it up. So this is a conversation that we're going to bring up going forward. With the teenage pregnancy, it's a good question. What I presented here is just highlights, and that is why we are always quick to put the micro data out there. Once we put the micro data out there, whatever analysis that we want to do to identify the drivers of teenage pregnancy, we're going to do that. The last question on the blood pressure, again, 2022, we did not consider that. Yes, it's true, 2014 we did that. But what we do at Ghana Statistical Service is that anytime we are about rolling out a survey, we bring to the table all the relevant stakeholders. They tell us the different interventions and surveys that they're going to run. The Ghana Health Service and the ministry gives us their priority areas, and then a decision is made on which one to prioritize at any point in time. Thank you.
Thank you very much. One of the advantages of having to speak after my brother has spoken is that I don't have to change the height of the mic. So, but that was a very informative presentation. For me, one of the take-home messages where we need to move away from, unless the data is from Ministry of Health, it's not good enough. This is national data. So this is the figures we should be quoting. And I think that came up in the earlier discussion where we have doubts. These are the figures we should be quoting. If these figures has come from WHO or the World Bank, we will be quoting them. And we should be using that rather than. But the other thing that I think came out very clearly is there are variations from regions. And therefore, we should not just be talking about the variations, we should do something about them. We heard someone say, we heard OT many times. What it means is that our best people should go to OT. So this is what it means by linking up with the human resources, that we have a problem in OT. If you want to go to OT region, these are your incentives. But more importantly, what it means is that if we don't do something about OT, we will continue to hear about OT region not doing well. The ministry should have a strategy as to how do we bring OT up to speed. And I'm proposing that our best people should rather be in OT and not in headquarters. So thank you very much for bringing. All right. The Director General says he will go there himself. I was not saying you go and come back. You go and stay there. Yeah. Yeah. Thank you very, very much. Any more questions? Yes.
Thank you very much. But I'm still not really clear about the maternal mortality data. So what are we doing? Are we going to have it? I mean, if it is not available, if the data is not collected, when is it going to be done? Because it's very key. We want to know where it is now so that we can work at it. And my worry is that if it's not done quickly, then it will be difficult for us to be able to compare, likes. Thank you.
So maybe the Director General can say something first. The question is, can you give us some indication when we're going to have the accepted figures?
Yeah, thank you. Maternal mortality is a very rare event. And so you need a very large sample size. DHS doesn't give us good data. That's why Ghana, we've never done that with the DHS. We normally do it every 10 years. We did 2007, 17, and we're hoping that 2027 it will be done. And then we'll be able to look at it. And the method we do, the direct method, gives us 4-year backwards. So if we do it in 2017, the mortality we have is actually for 2013, not 2017. And so I think that's an indication. It's the sample size. Otherwise, you have a wide confidence interval. I don't really know where your real mortality is. And that's why we do it every 10 years. And it's quite an expensive, large sample size, as Prof knows.
So his advice is, what figures should we be using now?
Well, we quote what we have now. We use this one. See, what we have, the institutional mortality doesn't necessarily cover everything. But this is a population-based study, and that is what we internationally. But for our own progress,
we can continue using our institutional data to measure progress. But as a national figure, these are more reliable than the institutional-based data.
Very good.
Yeah, thank you. Thank you, Prof, for
We'll
the
take two more after you.
presentation. My name is Stephen Duku from USAID. I want to highlight one very important issue that I think has come up the whole of this today. It's the issue of data, especially data at the MOH level. And I want to commend Dr. Insiabuatin and the team for putting together the holistic assessment, even in the midst of challenges in getting data at the MOH level. Clearly, a lot might be happening that the MOH is not in the position to capture institutional data and indeed other data from all of its agencies. And that is why I think it's important that if we have to prioritize anything in the health sector in terms of data, it should be getting a system at the MOH level that will be able to plug into all of the other systems at the various agencies, the data that they need to be able to conduct a holistic assessment that we expect of them, looking at how variant that data is from what the survey presented. And so we at USAID has just completed the process of hiring a firm to support the MOH, build such a system at the MOH level. Maybe at the initial stage, we might not be able to bring all the 26 or whatever agencies onto such a system, but we'll be able to do maybe the major 5, 6 or whatever at the initial stage, and we need to bring all of these agencies on board. The MOH might be coming to you, and we need the agencies to support. We can no longer hold on to some of these data. You need to allow them to plug into your system and pull the data, and as the system is up and running, we'll be able to add on and get other donors to support to do that. Thank you.
Very good point and good offer. Data, data, data. How can we strengthen data collection, and also how can we make this data also easily available to people who need them as well? Yes, Prof. Ampofu.
We have comments online.
All right. Can we take Prof. Ampofu first?
Yes, thank you, USAID. I think that leads me to my question. This year we heard about measles, an issue with lack of vaccine. There were some claims that there were some cases. There were some claims also that some children did not receive measles vaccination. So this data from the Statistical Service, it is for last year, because when I look at what you're reporting, 95%, that means that last year we had no issues with measles or any particular antigen. And for me, I'm very interested in this because, we are establishing the National Vaccine Institute. So we want to see where the gaps are, especially with the EPI program, and then use this information to assist our manufacturing, targets. So please clarify that this data that you've presented shows that there were no issues with measles, and this recent story about measles, is that just for this 2023 and not for the period that was covered by the survey? Thank you.
Very innocent question. Yes. All right, there's one question online. Can we take that? Then we take two from here and we will begin to wind up. Yes.
Oh, please, there's more than one. So somebody is saying that please consider adding other key sociocultural and environmental indicators in addition to religion. And then it says here again that globally we are focusing on integrated care, and these kinds of national assessments should begin to reflect global trends. And accordingly, the data should also be triangulated to reflect holistic RMNCHN assessment across the regions to guide investments. Then a question here is, to what extent has current educational policies contributed to the reduction in fertility? Those are the questions and comments from online. Thank you very much.
Thank you. Can we take the two questions from here? Yes, please.
Thank you, Mr. Chair. It's just a contribution to the maternal health data issue, just to comment that recently the World Health Organization has reviewed the methods that or the basket, the ingredient that are used to estimate the maternal mortality for countries. And based on the mix and other data, based on the bit of the improvement of the CRVS data that we have in Ghana, that estimate has kind of been reviewed downwards a bit. I don't want to quote figures now, but the entire document has been shared with the Statistical Service and our colleagues also at the Ministry of Health and the Ghana Health Service. But just to indicate that the current estimate that we used to quote has been estimated to come downwards. Thank you.
Yes. Please go ahead.
Yeah, thank you very much. I come from the Health Coalition. So my suggestion is, in terms of policy authority, I know the Ghana Statistical Service has that power to declare the data. So in moving forward, in a situation where a certain institution decides they will take up a data, can they also follow up or do some partnership to ensure that that institution does the data and brings it up? And also my second bit is, in the earlier presentation, we saw, during the appraisal, we saw that there were some disagreements. Moving forward, can we also bring the Statistical Service to come in such that those data that comes up can be validated moving forward, so we don't be waiting for funding to start all over again? Thank you.
All right. Good questions. Prof, you are the authority on inflation rate. Can you also be authority on some of these figures?
Yeah, thank you, Chair. I think mine is just to make some clarification from what Mr. Duku said. I think he sends the wrong message out there, as if somebody is hiding information from Ministry of Health. The access that I have for DIMS and the access that Dr. Fosu has, the same access the director at the Information and Research has. So if there's a need to pull data somehow, it should not be made as if some people or some facilities are hiding information from the minister. And I want that to be very clear, because that's the information. This is a big platform, and I don't want that message to go out thinking that someone, because the information that Dr. Atiwoto access is the same as I have, as the Director PPME has, and it's a question of getting you a password to put it. The data is generated from the facility, and everybody has access, and I think I want to make that very clear too. Especially when he worked at PPME for many years before he left.
Prof, any final comments?
We are keeping the mic's position where it is. So thank you for those questions, and Chair, my final remark as well. So the data was collected from the period October 2022 to January 2023. So that is the period that we are reflecting this data. Yes, 95% has been put out there, but let's keep an eye of children who have not received any form of vaccination. That is a 2.0%. I'm always concerned when there is the tendency to mix percentages with absolutes, because once you want to look at the absolute for the 2%, it might be responding to the concerns that you have, and especially where we are finding those 2%. And even between the ultimate 100% and the 95%, where the 5% are, in terms of absolute numbers, it's also something that we need to think about. I did indicate that the data, it's so rich, so whatever analysis that you want to do, whether individual level analysis, household level analysis, community level analysis, we are able to do that. The beauty about the census data, the GDHS, and all our upcoming survey is the data on GPS coordinates that we are collecting. And this responds partly to the issue of triangulation. Once we are collecting data on coordinates of structures and where we know where the data are coming from, the excuse that the sample is representative only at the regional level is a thing of the past. clearly going forward, we can do analysis at the district level, we can do analysis at any small area level to help us better understand what is happening. The question on education policies, thank you so much. It's a very good question, and I'm looking forward to we as a country being able to have registers from the health perspective and registers from the education perspective. Now, there are a number of ongoing discussions to see how we can superimpose the health data on the NIA, going forward, how we're going to superimpose the education registers on the, NIA, the National Identification Card. Once we are able to get there, like it's done in other jurisdictions, especially the Scandinavian country, we can do whatever analysis that we ought to do. But this comes back to the conversation that the DG reacted to it earlier on. Until we have a national consensus on how data has to be integrated, we're going to have a challenge. And that is why Ghana Statistical Service is now holding a committee of National Statistics Advisory Committee. And they are meeting regularly, and this partly answers the question. They are meeting regularly to ensure that as a country we have data quality assurance framework, and then the committee would have the responsibility of reviewing all the institutional data, all the surveys, all the censuses, all the surveillance that we are doing, and put a stamp on it that this is an official statistic and this is an experimental statistic. Until we get to that point, we're going to have these variations in whose number is right. And colleague from USAID, thank you, you brought up that point. My concern is that now there are a number of development partner interventions that are trying to digitize data across different institutions, and these interventions are happening in silos. It's not going to help the country going forward. We need to really bring all these together to ensure that if an institution wants to digitize, if an institution wants to rely on its administrative data to provide statistics, how can we do it in a synergistic way? Until we do that, USAID will do what it's doing. Currently, the World Bank is supporting both the ministry and the Ghana Health Service to ensure that we have interoperable data systems. So if USAID is doing something which is not taking into consideration what the World Bank is doing through Ghana Statistical Service, we're going to see these things operating in silos, and later on the technologies will not speak to each other, and we have to go back to the drawing board. And we have such examples with other institutions already. So, Chair, I think these are my last words, and thank you very much for the opportunity.
Thank you so much, Prof. I dare not touch the microphone. The last but not the least presentation, ladies and gentlemen, will be on the highlight from the Harmonized Health Facility Assessment Survey. And trust me, Dr. Alberta Birichum-Nyako will do this so simple. Let's welcome her to do the last presentation for us. But this is not. No. So just as we try to upload her slides for her, just some quick announcement. Because we've kept you waiting, there's an assurance of another snack before you go home. You want to take it away? No. So it will still be taken right after we've closed. It's just a way of compensation. Just a way of compensation. So we rest assured. Thank you for your patience once again.
Okay, good afternoon, everyone. Dr. Chair, please permit me to stand on already existing protocol. On behalf of the Director General of the Ghana Health Service, I am supposed to share some highlights of the Harmonized Health Facility Assessment. And I'm waiting for my slides to be uploaded. But I must say that the Harmonized Health Facility Assessment is a standardized tool that can be used to assess the quality of services that are provided clinically. It also helps us to know where we are at in terms of availability and readiness of the services that we provide. As a country, as we inch towards universal health coverage and also attaining the health-related SDGs, it is important that we know where we are at. So conducting this harmonized health facility assessment has been useful for us. We are still doing the interpretation and the writing, and when all is done, the full document or report shall be launched. It's a standardized tool. We call it the Harmonized Health Facility Assessment because it is a combination of other standardized health facility assessment tools. For example, the USAID Service Provision Assessment, the World Bank's Service Delivery Indicator Survey, and the WHO Service Availability and Readiness Assessment. All these are included in the Harmonized Health Facility Assessment tool that we used. The survey was mandated by the Ministry of Health, and Ghana Health Service was given the task to get it done. Technical assistance and financial assistance was received from WHO, and we have worked with them. There are technical committees, there are steering committees of which CHAG and other partners are also part. And within the Ghana Health Service, the DG has the overall oversight of the implementation, the assessment, the interpretation, and the writing, and the key divisions that have been working on the assessment are the Research and Development Division, the PPMED, and Institutional Care Division. So when my slides are uploaded, we shall just share some highlights of the survey as we have it now. Thank you very much. So as I've already given the background, the HHFA is a comprehensive standardized health facility survey that provides reliable, objective information on the availability of health services and the capacities of facilities to deliver the services that are required at the standard of quality that we require them to be. And it's important that we see where we are at if we want to ensure that we leave no one behind going forward. The specific objectives are to assess the status of health facilities in the country, to assess the type, the quantity and quality of health services that are provided to the people, to also provide data for monitoring and measuring changes in the kind of services that we provide, as well as the readiness and the availability going forward. The fourth objective is also to provide some external validation for self-reported information on service delivery, the quality of care and system functions. Last but not least, to generate evidence that will feed into our planning, resource allocation, and others going forward. So there are 4 modules of the health facility assessment. The first module is on service availability, the second is on service readiness, third is on quality of care, and the fourth is on management and finance. We actually did the first, second, and the fourth. So the first one on availability looks at the staffing, beds, facility characteristics, services that are provided. And the readiness also looks at staff training, guidelines, equipment, medicines, and such. The quality of care looks at how we adhere to patient care processes, and the finance and management, as the name suggests, is about management issues, governance, health information systems, quality assurance, etc. We only did number 1, number 2, number 4. It's actually a facility audit. If we had done the quality of care, that one would have meant that we have to do detailed document review. So the methodology is different. Facility audit for the first 3, and then a deeper document review for the quality of care module. Perhaps by the end of the year or next year, WHO would give us the technical support and the financing support again to carry out the quality of care module. But it's also important to note that the 3 modules that we worked on have inherent in them quality measures. Then again, the World Bank is supporting Ghana Health Service Ministry of Health to conduct the Service Delivery Indicator Survey, which would be the baseline for the networks of practice going forward, and it shall be repeated again in 4 years. So we still believe that there are other sources of information that would give us an idea of the quality of care that we are providing across board. So it's a cross-sectional survey, a national survey. We could have done a census, meaning that all the health facilities would have been assessed, but we did purposive sampling, which is also accepted. So we chose all the regional hospitals, all the district hospitals, all our polyclinics, and then for the health centers, maternity homes, clinics, and CHIPS compounds, we did purposive sampling, making sure that the first phase of facilities that would form part of the networks of practice were included. It also covered private facilities and public facilities as well. And the survey was quantitative in nature. We did physical data collection. So as I've already said, it was led by the ministry, and funding support and technical support was from the WHO. So 1,421 facilities were assessed. 21% of these were district hospital or other hospitals. Just 1% was for our regional hospitals, and we're not surprised because there are only 16. Polyclinics formed 5%. CHIPS compounds 23%, health centers 28%, maternity homes 5%, and clinics 17%. It's important to note that the responses were weighted to give a good representation of what actually happens in the country, and also to justify for some huge numbers of various facilities. So this is the geographic distribution of the facilities that were assessed in the survey, and the survey was conducted late 2022. So some preliminary key findings. We realized that of the 1,421 facilities that were assessed, 24% of them were providing inpatient services. We were surprised, however, to find that 13% of health centers and 28% of maternity homes and clinics were also providing inpatient service. And I think it's one of the things that we're going to look at going forward. Should we encourage it? Yes, some of them were private facilities, and that is what they choose to do. But we also have to weigh it against, should lower level facilities hold on to cases that perhaps should have been referred for better outcomes. These are some of the things that we must discuss afterwards, because the HHFA does not give us why we observed what we observed, but it shows us what is happening in a snapshot. For service availability for malaria, of the 1,421 facilities, 97 facilities were providing malaria testing and treatment services, and 86% were providing same for HIV. But for tuberculosis, any kind of service, whether it is for testing, treatment, or follow-up of cases, it was quite low. That was 53%. 96% of facilities surveyed were using RDT for diagnostics, and 39% had the capacity for microscopy. For neglected tropical diseases across the 1,421 facilities, only 25% facilities were offering some service. But when you took a closer look at district hospitals, it was seen that 68% of district hospitals were offering some form of service for neglected tropical diseases. And nationally, it ranged from 6% of service provision for visceral leishmaniasis to 22% for soil-transmitted helminths. For preventive and or curative care for children under 5, generally it was high across the facilities surveyed. That was 93%. Access to newborn care services was also quite high, 81%. And care for small and sick newborns was low. This is more of a specialized service, and we found it in only 15% of services, facilities. For RAMCA services, reproductive, maternal, newborn, child, adolescent health services, largely most facilities were providing one or other of these services. And we realized, however, that only 20% of facilities surveyed were providing CMONC services, that is comprehensive emergency obstetric and newborn service. Similarly, 66% of facilities across board were providing BMONC service, that's the basic emergency obstetric newborn care. And for facilities that were lower down, that is below the district hospital level, we realized that only about 15% of facilities were actually performing all the 7 signal functions. This also means that there's a lot to be done, because basic means basic, and facilities in the sub-district level, especially health centers, must be able to provide BMONC services. For these facilities that were providing BMONC services, 54% of them had checklists or job aids on essential childbirth care, and 31% had guidelines for essential childbirth care. Only 29% of them had guidelines on essential newborn care. For facilities that offered some form of service for management or diagnostics for non-communicable diseases, across board was 53%. And for hypertension and diabetes, it was mostly 45% of facilities that were providing these services. For any type of cancer, whether it was detection, screening, we had only 17% of facilities offering some form of cancer service. For blood transfusion, about 25% of the facilities surveyed were offering blood transfusion. Only 30% of these facilities had guidelines on the appropriate use of blood and safe blood transfusion. And only 57% of the staff in these facilities said they had been trained. On equipment, 27% of facilities surveyed had ultrasound machines, and less than 5% had fluoroscopy services, CT scans, or mammograms. For MRI services, they were largely lacking. So even when you compute it, you get 0.00 something. So it does not even show on the graph. And for our 16 regional hospitals, I think it's only Greater Accra Regional Hospital at Ridge that has an MRI. So there are more details on where the equipment can be found. On emergency preparedness systems, only 11% of the facilities surveyed had a written safety plan. 11%. And 7% of facilities surveyed had emergency response plans for outbreaks. And this is quite surprising, as we have been with outbreaks for the past 3 years. Last year in particular, we had so many outbreaks, and yet only 7% of facilities surveyed had any emergency response plan for managing outbreaks. 2% of facilities surveyed had emergency response plan for a natural disaster, like, say, flooding in their area. On governance, 62% of facilities had held a management meeting in the 3 months preceding the survey. 62% had held at least one management meeting. 45% of facilities have a routine system for eliciting community inputs in management decisions, and 70% have a formal system by linking with community health workers in their catchment areas. On maintenance, 55% of facilities have routine maintenance systems in place for vehicles, and only 15% have routine maintenance for infrastructure, such as electrical systems, water, sanitation, or sewage. All the regional hospitals had annual budgets and work plans, but 70% of district hospitals could talk of same. And when we drilled down to the CHIPS level, only 11% of them had annual work plans with budgets. Summary of the key issues. We are still in the interpretation and writing, but for what we have just presented, it's important to note that across board, guidelines are largely unavailable, and we have to find out why. We also have to find out in what mode staff prefer to use or refer to guidelines. Do they just want soft copies? Do they want it on walls? Do they want it in WhatsApp mode? What is it that would make them use the guidelines so that we adhere to the standards? Also, I think we all agree that TB service provision could be improved, because we're talking about from screening to testing and also follow-up. Lower level facilities that are offering inpatient care, whether it's private or public, it's something for us to look at and ensure that patients do not suffer unduly because lower level facilities are holding on to them. And that also has cash implications for the lower level facilities, but may also be inimical to the outcomes for these cases. When it comes to neglected tropical diseases, it's about time we opened up and ensured that service availability is beyond the 25% that we have seen. For BMONC services, we've already concluded that it is basic, and facilities in the sub-district, especially health centers, must be able to offer the full repertoire of BMONC services. Also for cardiovascular health, I think NCDs are top on the radar, and not all complicated cases can be managed at the sub-district, we agree, but so much more in terms of screening and follow-up could be done at the sub-district level, and so we must look critically at it. Routine maintenance systems are not optimal, as I've just shown. Emergency preparedness across board is low, and we cannot continue in that same mode. So something differently must be done. When it comes to equipment and diagnostics, it's just a few far in between. And in fact, most of our referrals actually happen because of the need for diagnostics. So what are we going to do as a country about it, so that it is not just within a specific enclave, but it is largely available across the country? For blood transfusion services, I'm glad the CEO is here. We know that we have a huge gap, but as she has already started discussions with the DG, they also have ways in which to meet us at the point of our need so that we can have blood services closer to us. Also, to conclude, as we are doing the interpretation and the writing, that is just the beginning. It is the hope and the aspiration that divisions, programs, regions will take the data, understand it, own it, and use it to identify the gaps that must be addressed. So that when we meet here in a couple of months' time or years, we're not going to talk about the problems, but we're going to talk about how we tried to address the gaps that were in the HHFA. The full report shall be launched later, and all the details shall be shared with you. Thank you all for your attention.
All right, thank you. Okay, the chairman is also here. Questions, maybe briefly. Yes, so we have one. Any other? Any other? Okay, so one for now. Two. All right, so let's take the questions available. Online, if you have questions, please stand by.
Thank you. That's a good presentation. I wanted to know whether you involved HIFRA in this research, and then also whether the private facilities were considered. I thought that, it's important we look at the private facilities also, especially, at the level at which you are conducting this research. Thank you.
Very well. Yes, please.
Yeah, thank you very much. Mine is very simple. I think one of the thorny issues that came up in the HHFA report or findings is in respect of the real definition of what a policy is when we talk about its dissemination. Is the dissemination defined as where the TOTs are invited and they are trained and the policy is given to them? Do we define that as the generic definition of a policy being disseminated? Because it looks like it's all across the feedback we got from some of the facilities, especially those who were involved in this exercise. They deemed the dissemination of the policy as having been done when the TOTs are gathered and trained, and then the documents are provided them. So I think this clarity must be provided, especially when we have the Director General here and then the Director of PPME as well. Thank you.
Okay. On the back.
My name is Dominic from GAFTRAM. I wanted to know whether this survey considered herbal facilities in Ghana. And if not, are there plans to consider them when they are doing the next survey? Thank you.
Very well. Okay.
Yeah, thank you. Mine is just a little clarification on the percentage for the CMONC facilities. You mentioned 20% of facilities offer CMONC, and I was a bit alarmed, and I wanted to know what the denominator is. Is it all facilities? Because we know that it's not all facilities that are expected to offer CMONC. So if you can clarify what we are looking at.
Okay, the very last one at the corner there.
Yes, thank you very much. The name is Labran Musa from the Ghana NCD Alliance. So, Madam, thank you very much for at least emphasizing the fact that we need to prioritize cardiovascular health at the basic level. Indeed, the WHO PEN Plus has encouraged African government to prioritize non-communicable diseases at the basic level. So I'm happy that you touch on that. And then also wondering if you have considered preventive or health promotional measures within the health facilities, whether how far we are doing when it comes to issues of preventive and promotional measures to reduce our disease burden. Thank you very much.
All right. Otalinda, do you have any online? Maybe just two. It will be the last one. If not, over to you, madam.
Hello.
Oh, okay. Thank you very much for your interest and for your questions. I must say that I'm not here alone. Of course, my DG is here. I just did this on his behalf. He knows. And then we also have WHO here. We have research division, I think ICD as well. So I will do what I can and they shall support me. The first question was from Dr. Divine about whether HEFRA was involved. I think the ministry can answer that one. I am not sure the engagement they had with HEFRA, but it included the private sector, it included CHAG, because we just picked the facilities purposively. But I am not sure I can answer that one on HEFRA. And then Dr. Anaman asked a question about how do we define policy dissemination. I am not too sure whether that is what I present. I actually presented on guidelines, not the availability of policy documents, but the availability of guidelines. And it is from the policies that guidelines emanate. So the guidelines were not available. That which was available was seen, whether it was guidelines in a book form or a checklist or a job aid. But that was what was seen. For the policy that you are talking about, I am not too sure if that was covered in the HHFA. But since you already deflected that question to DG, I will let it rest peacefully on his laps. The third one is on the involvement of herbal facilities. We did not particularly sample herbal facilities, but the Ghana Health Service facilities that have in them herbal clinics are 55, and all of them were included in the assessment. Then there was a question on CMONC. Yes, the CMONC 20% is on a denominator of 1,421. That is all the facilities that were assessed. So that is where the 20% is coming from. And as you rightly said, it's not all facilities that we expect to have CMONC, but we think that BMONC should be at least in all health centers. And that one was actually 10% when you looked at health centers in particular. Mr. Labram Musa also talked about the need to have NCD care strengthened at the basic or sub-district level. And that is one of the things that the Ministry of Health, Ghana Health Service shall be doing when the networks of practice also begin in earnest. This study did not look at health promotion or prevention when it comes to NCD care, but I can assure you that the Ghana Health Service and the ministry are working on this. Thank you.
Is there anything to add? Okay. Please, Mike, DG. Ministry, do you have anything?
Thank you. I don't know Anaman's question, whether it is because they didn't know, that's why he's asking a question, or whether it's because dissemination did not take place. I believe that we do dissemination. And dissemination is not when you are doing a TOT. When you have finished everything, dissemination can be here, people are making inputs. That may not be the final one, but eventually it will be disseminated. But I believe that what you meant was that are they dissemination? Yes, there are some documents that are produced that are never disseminated. It's no problem. That one we are aware. But dissemination is that you have to disseminate to the key stakeholders to the lowest level. It doesn't always happen, but those are some of the things we need to make sure that even this HFFA is actually carried out as well. I have my own issues with the denominator issue of CMONC should be hospital, not health center. So otherwise, it's difficult to compare with other data if you use health centers and measure them by CMONC. You cannot compare with other comparative data. So I think that's something we need to look at.
Very well. I don't know whether Director PPME, Minister of Health, any clarity? All right. Not for now. Very well. Thank you. Okay, the very last one.
So just to add to DG's comment that, yes, in terms of the CMONC, the data was stratified by the CMONC facilities only. But WHO also wanted to know within the population or within all the facilities, how many other facilities are actually offering CMONC services. But there is also a stratified just for the hospitals, just for the regional hospitals. So those denominators are there. And it's been stratified by BMONG facilities, CMONG facilities, and even EMONG facilities. So those data are available. Thank you. And just to add that, yes, HIFRA was invited during the 2 adaptation. Before the survey, all the key agencies through the ministry and other things, they were invited for the 2 adaptation to ensure that the 2 that was going to be used was adapted to the Ghana context. And there were even Ghana-specific questions that were tailored and indicators developed for that. Thank you.
Thank you. Dr. Vanuatu, any question online before we close?
Thank you very much. Well, one of them is, are these standards, all these standards are in HEFRA assessments. And so I think he's just asking about facilities licensed by HEFRA. That's what somebody wanted to know. And then, please, were Pasai government hospitals and clinics considered in the data? And then can we get data disaggregated by CHAG, private sector, and GHS? So that is what they wanted. But somebody also wanted to draw attention that he or she thinks that the question Stephen asked was highlighting the need for integration of data sources of all the agencies within the ministry, not just the Ghana Health Service, but all the agencies. So that was just to clarify that point. So these are what I have online. Thank you.
Very well. All right. Madam, anything to address?
Yes. Thank you very much for the questions. I think there was an observation that some of the questions are in the HEFRA accreditation tool, so it shows that it's standard. That's fine. And for the data aggregation by facility type, yes, we can get it for you. Thank you.
Let me keep this to myself. Let's invite the chair today to give us the closing remarks. Anyway, let's welcome him.
Thank you very much. I'm very happy to disappoint those who are expecting closing remarks. Very good presentation, Alberta. Very good survey. I'd always known Alberta as a very straightforward person. I didn't know she was so diplomatic. Referring to the DG, she was speaking on behalf of the DG. But on the survey that we've just heard, I mean, I'm sure some of the findings are not news to many of us, but there are some that are a bit scary. So I was thinking, will we be comfortable if this, for example, is reported on one of our TV networks? How will people view the health sector if this data, this information goes out? I was just thinking. So I'm suggesting that the meeting where we're planning to launch the report, maybe it should not be just a launch, but also at that meeting we should outline what steps we are taking to address some of this issue, so that it's not just a launch of the survey, but we've already, because we've been primed as to the findings on the survey, and some are worrying, but of course it's a true reflection of the situation we have now. We've had a very long day. I'm not going to make it longer by attempting to summarize. I always say to summarize, it means to sum. And when I went to school, sum means add. So in attempt to summarize, I may add my own. So I won't do that. I just want to thank you for being just a wonderful audience and for bearing with us for the inconveniences, not starting on time and all the delays and all. Thank you for the work that has gone on today, and I'm hoping that even tomorrow will be much, much better. With that, can I hand over to the MC?
Thank you very much, Doc, for making it simple for us as well. I still want to acknowledge our sponsors, UNFPA, UNICEF World Vision, USAID, World Bank, Gavi, WHO, Farm Access Foundation. Let's do it for them. Thank you so much for sponsoring us. We duly acknowledge that as well. We are meeting here tomorrow by 8:30 a.m. 8:30 a.m. And we mean 8:30 a.m. And we hope and anticipate that you'll surely be here. And we promise to really start on time as well. So our snacks will still be at the gardens, Omani Gardens, for us. We duly acknowledge Dr. Linda Vonotu online. Thank you so much for the support. Mr. Benjamin Nyakuche, thank you so much for the support. Tomorrow, God willing, my senior brother, Mr. Kwame Deya Samotri, will be hosting us for the day as well. And thank you so much for cooperating with me. I am Naftali Ewachiche Bafo as well. And thank you so much, Mr. Chair. We always learn a lot from you. And I want to apply the amber. Let us go very fast to our respective homes right now. Thank you. I humbly welcome Dr. Anastasia Renchi to give us the closing prayer as we run fast to our various homes.
Dear Dr. Chair, our honorable facilitators, DJ, directors, distinguished ladies and gentlemen, you all agree with me that we've had a wonderful time and God has been gracious to us. At least we haven't had any casualties. Nobody has been rushed to the hospital. So on this note, please kindly rise to your feet and let us give God his due. King of Kings and the Lord of Lords, we thank you for how far you've brought us. Since the beginning of the program, we called upon you. And your gracious and your mighty hand had been with us. The hand of providence had gone through us with us, all our deliberations, all our discussions. Father, it is our prayer that as we are living and not living your presence, Lord, you take us to our various destinations where we came from. And any virtue that had gone out of us, we are asking for replenishment in the mighty name of Jesus. Lord, we thank you that tomorrow you'll be with us also. And by the time we are ending the third day of our health summit, Lord, we will have solutions in our hands. We give you all the praise, Father. We give you all the glory, Lord. And we give you all the adoration in the name of Jesus. Now, may the Lord bless us and keep us. May he make his face shine upon us and be gracious to us. May the Lord lift up his countenance upon us and give us peace now and forevermore. Amen.
Please, there's one. No offertory.
I was about to say that.
Agents appreciation. Yeah.
All rapporteurs are meeting right now, so don't be in a hurry to go. Rapporteurs, you are meeting right now. Thank you so much. MWH Choir, thank you so much. We really appreciate what you did. We hope tomorrow you'll minister to us as well. Thank you.